So folks, a very good morning to you. Welcome to this Rare Diseases Access Initiative Symposium. I trust I've got that right, Kelly. My name is Trevor Warner. I'm just the technical guy behind the scenes that's hopefully going to help us to achieve a nice slick product this morning. And I'm going to give you literally just a 90-second little intro as to some of the ground rules for how this morning is going to operate. So folks, welcome. Numbers are still ticking up. We're up to 50 now, those of you on the panel. And that's fantastic. I think we have just over 100 registrations. Numbers are rolling in nice and quickly. But just a couple of little pointers. So you're in a webinar, folks, not in a meeting. You don't have to worry too much about webcams and microphones. You actually don't have access to those. What you do have access to, which you don't have in a Zoom meeting, is a Q&A panel. And I would encourage you that should you have questions relating to the content of today's webinar, that you actually use the Q&A panel rather than the chat. Keep the chat for the less formal stuff and keep the chat for comments or questions or issues that might relate to my helping you. If you've got an audio issue or some sort of a connectivity issue, you're welcome to pop something into the chat and I can maybe try and help you deal with that. But keep the more formal questions in the Q&A if you would. It's just a little bit easier for the panelists to manage them like that. One other little point I'd like to make is obviously going to be the sharing of multiple slide decks during the various presentations today. And at the moment, you should be seeing my webcam image adjacent to a slide. You can actually resize those. So if there's a lot of detail on the slide and you're struggling to actually see that the detail that you require on that slide, then hover your cursor between the webcam image and the slide deck, and you can actually resize those quite effectively. And I see whilst I've been speaking, we're up to about 60 now, and that's fantastic. So we're now just a couple of minutes after 10 o'clock. If you've just joined in, welcome. I'm going to be handing over to Kelly Duplessis very shortly, who's going to introduce the proceedings for today. And I'm in the background. If anybody needs me, over to you, Kelly. Thanks a lot.
Thank you very much, Trevor, and a warm welcome to everyone who's joining us today. Those of you might be here on the Zoom platform, others might be joining us via our YouTube link, and it's a really, really warm welcome. We're very, very excited to be hosting this meeting today. Just a little bit of background with regards to the Rare Diseases Access Initiative, who we are and what we are intending to do. So essentially, the RDAI is a steering committee that was formed as a coalition of interested groups with the aim to promote an environment which is favorable for those with rare conditions. And in particular, the participants seek to improve equitable access for those who need it. But we do not currently have access with regards to diagnoses, treatments, healthcare services, regardless of the healthcare sector utilized for many of our patients across the country. So I really want to reiterate that this group has come together to develop a country-orientated solution. It's not a private sector initiative. It's not a public sector initiative. This is a South African problem, and we are looking for a South African solution. So for those of you who don't know, there are many South Africans, approximately 3.7 million South Africans who are impacted by a rare condition. And we really are wanting to see them have an extended and improved quality of life, where they are able to freely access appropriate healthcare services without barriers. And people with rare conditions often have very, very complex needs and face very unique challenges. And also just to mention that rare diseases are not necessarily just a healthcare issue, although healthcare is what we'll be discussing today. But the life of a rare disease patient is impacted by education, by disability in the workplace, via accessibility, stigma, isolation, financial hardship. So it really is a complex problem. And they are often life-threatening, life-limiting, or chronically debilitating conditions. They are often complex, impacting multiple organ systems, and require specialized and coordinated care that comes at a considerable cost to families as well as the health system. And 80% of rare diseases are genetic and therefore not readily preventable. So it's not a case of if we educate better and we do a lot more awareness, etc., that will eradicate the problem, because the problem will still exist. People, often children living with rare diseases, fight against their diseases each and every single day. And unfortunately, in many cases, the health system is just simply not equipped to respond to the needs of those living with rare conditions. So today we are hoping to really analyze and discuss some of the barriers and the challenges that we've seen. You would have received the draft framework document prior to this meeting that we have circulated. And this is one of the first working documents that has come out of this Rare Disease Access Initiative. And we are really looking to use this opportunity today as an opportunity for engagement around some of these issues, and also to identify if we have missed anything that's obviously pertinent, and just to get the feedback from the outer broader stakeholder grouping. So we have a really interesting lineup of speakers today, and we're really excited to hear from all of them. I'm going to start with the introduction of our very first speaker, who we are so grateful agreed to assist this morning and give us a little bit more information with regards to the National Health Insurance, and that is Dr. Nicholas Crisp. Dr. Crisp, for those who don't know, I'm sure he needs no introduction. We've seen a lot of him over the last couple of months, particularly with the COVID front. But Dr. Crisp is a medical doctor and a public health specialist who has for many years focused on health management consulting across the African continent. And he's been involved as a consultant in many different countries, including Nigeria, Ghana, Lesotho, Botswana, Namibia, and Tanzania. And in 2009, he served as the special advisor to Minister Barbara Hogan, and he was intimately involved in the establishment of the National Health Laboratory Service, as well as the transfer of the medico-legal mortuaries from the police service to health, and the creation of the forensic pathology services. He's now obviously very involved and has been tasked by the Minister of Health on the implementation of national health insurance, and is also very busy on the COVID front, as is everyone working in healthcare this morning. So we're really grateful. Dr. Crisp did advise that he is a little tired of PPTs, PowerPoint presentations, as I'm sure we all are. So he's merely going to be speaking to us, which I'm quite excited for because I'm lacking conversation. And Dr. Crisp, if I can, moving over to you.
Thanks very much, Kelly. Good morning to everybody. Nice to be with you. And thanks for indulging me in not having a PowerPoint presentation. I really am tired of them now. I have to prepare new PowerPoint presentations, sometimes twice a day for COVID. And really, it's not the ideal way to try and communicate what we're trying to say. So I've been asked to give you a little bit of insights, but a little bit more information about national health insurance, and obviously to put rare diseases into the context of where we are going with national health insurance. So let's start with a high level. National health insurance is a financing mechanism. And through that financing mechanism, it intends to change the structure of the delivery of the health system. It is a massive reform. And it will not happen overnight, and it doesn't happen in big tranches. It happens slowly over time, and it's sequenced with a lot of changes that happen, have to wait until other things can happen before they occur. So what are we trying to achieve? And then I'll tell you where we are with the process at the moment. What we're trying to achieve is a situation where nobody pays for their healthcare at the point of service delivery. We want to have that the entire country is pre-financed. All our healthcare is pre-financed by us as the people who live in the country through the taxes that we pay for everything that all the services that we get, not only healthcare. I'll talk a little bit about how we're going to afford that and where the money comes from and how it will flow and how it needs to change in a moment. So the idea is that the fund, the National Health Insurance Fund, will be an entity of government, like a bank, if you like, that is responsible for the purchasing of healthcare on our behalf. It will purchase benefits that are defined by the fund and endorsed by the minister, in other words, approved that they are affordable for the fund, and it will not cover things that are deliberately excluded from the fund, and those will be made public. And I know immediately people with rare diseases think they're going to be excluded, but that's not what one tries to exclude when you determine benefits. What you try to exclude are things that are wasteful and things that have never been proved to be effective. You don't try and exclude genuine causes and genuine concern from patients who have clinical conditions. So we'll come back to that in a moment as well. So the intention is that the fund will then purchase from providers. And so we call this a single funder model. That's not to say that there won't be some medical schemes covering things that are not covered by the fund, but essentially we're moving towards a system where there's primarily a single funder that is paying for our benefits and purchasing those benefits from providers who have been accredited by the fund. And the bill is very clear, and the intention has always been very clear that those providers will be both public and private providers, from the periphery of the health service in the primary healthcare domain all the way through to super specialists who are required, plus the services of diagnostic specialists like radiologists and radiographers and people who work in that environment, labs and so forth. So we are looking at a single purchaser model with a purchaser provider split. And the intention is over time to work towards what's called universal health coverage. Now, everybody talks about universal health coverage and agrees with it, but they agree with it on condition there's more than one universe. And that's not what the National Health Insurance requires. It requires we have universe means universe, one. We will have one universal program that we all benefit. And the only reason that we get healthcare is not because we can afford it, but because we need it. So moving from where we are now to there is going to require a number of quite tricky steps. The first one is getting the legislation in place, which is the National Health Insurance Bill that's in Parliament at the moment. And those kinds of bills are only enabling legislation. What the NHI bill will do when it becomes law, it will amend the National Health Act to change the responsibilities and functions of various authorities, including the provincial health departments, and to make sure that the financing of healthcare is entrenched in law. Whereas at the moment, it's not entrenched in law. It is purely in the public sector, a function that is in the provincial equitable space, if you like. So we call it a provincial equitable share of the national government's allocations made to provinces goes to the province as a whole, and then each province allocates money to health and education and other bits and pieces. There's no such thing as the national budget at the moment. We have 10 budgets for health in the public sector. And at the moment, the private sector financing of healthcare is governed by the Medical Schemes Act, not by the Health Act. And the Medical Schemes Act makes provision for medical schemes under certain conditions. And at the moment, there are 74 medical schemes, each with many different packages. And if you can even guess what's in your own package and what's covered by it, well, then you're smarter than I am. I haven't worked mine out yet. So we have a very complicated financing arrangement in our healthcare in South Africa at the moment. And for this complicated healthcare, we spend 8.5% of our GDP, which is a sizable portion of a very big GDP. We are about the 30th biggest economy in the world, and we don't get the outcomes that we should get. In fact, if you look at the scoring of health outcomes compared with inputs, we are amongst the worst performing health systems in the world, which is not a very nice position to be in. So what we want to do is we want to get to a situation where we don't have two universes. We don't have so many different financing streams that are very complicated and exclusionary by design, and where we have all providers, public and private, accessible to everybody purely on the basis that you need the healthcare. Now, 8.5% of GDP is many billions of rand. At the moment, it's over 500 billion rand, of which more or less half is spent in the public sector and about half in the private sector. The half in the public sector, as I've indicated, is 10 different budgets, the 9 provincial budget, then a very small national budget, and a whole host of conditional grants that the National Treasury has allowed the health authorities, the health department, to supplement what provinces are unable to manage within their own budgets. It's an unnecessarily messy, complicated environment at the moment that we are trying to simplify. Then on the private side, there's the pre-financed healthcare, which everyone's familiar with. That's the medical schemes environment. And then there's out-of-pocket spending, which is substantial. It could be as much as 100 million rand that we spend out of pocket as South Africans by purchasing either consultations or medication or other forms of care. So at the moment, what we are moving towards is in the initial phases, one, to create the office that will design the details of the fund. There has been a lot of research done over the years, but now it's getting to the point where we need to publish what are the benefits that the fund will cover and how are we going to describe and measure them, and then what are we going to pay for them. The idea is that no matter who the provider is, there will be a fixed cost of payment. In the primary healthcare environment, what the bill says is that the fund will pay a capitation fee to a contracting unit for primary healthcare, which includes a wide range of primary healthcare providers, and that will be probably a weighted capitation fee, depending on the conditions in that area, the gender distribution, the age distribution, and so forth. And that will be paid to general practitioners, pharmacists, public health clinics, community health centers, and community health workers, etc., the people who work in the primary healthcare environment. The intention is for the hospital environment that care will be paid for on, let's call them diagnostic related groups. There are various models available to us, but it's where you don't pay a fee for service. You pay for an outcome, and that outcome can be weighted in severity and have different costs associated with it, but it's a described outcome. And then there are other bits and pieces of support for those outcomes, which might be financed through other mechanisms, but primarily those are the two mechanisms. Now, there are many countries around the world who have already moved to these models, so we are not the first ones, and we are not piloting something new. What we will be doing is working on models that are not dissimilar to where we want to go, and we will be sharing and learning, as we have already, from those models around the country, around the world. Now, moving from where we are now with this very complex environment to the new one is going to need to be done in phases, clearly. The first phase will be, other than setting up the office that's able to manage this, is the primary healthcare environment. Now, to do that, one needs to remove the budget from the public sector. Now, that in itself is quite a lengthy and difficult process. The law says that funds follows functions. So what the National Health Insurance Bill will do is to remove the functions for the delivery of healthcare from the provinces, put it into the national budget. That means the money must move to the national department to be placed into the National Health Insurance Fund. And then the Minister of Health may delegate just the delivery portion, so the service provision portion, back to the provincial administrations and even to local governments or NGOs or anybody else, but primarily it will go back to the provincial administration. So they become no longer a purchaser and a provider, but only the provider. And the bill says that the National Health Insurance Fund will buy directly from the provider. In other words, not through the provincial administration. So not creating a new budget structure within the provincial governments. Now that is complex shifting of funds, and in order to avoid breaking the system, what one normally does with these kinds of big reforms is to run the new system in parallel as a shadow budgeting and spending framework to check what the impact is going to be on the current spending and allocations. But what will happen over time, obviously, is that where we are underspending on certain communities, that becomes very stark reality when you start looking at it on a per capita allocation rather than on continuing on incremental budgets, which we do now. So I don't want to go too much into that, but obviously it does impact on rare diseases because, as we've heard in the introduction, rare diseases are not about only very expensive clinical care in tertiary environments. They're very much about lifestyle. supporting people in their home environments, and much of that happens in the primary healthcare space. So it is important that in the primary healthcare budget, when the contracting units have their resources and we contract the providers in that space, that they're able to provide that portion of healthcare, whether you have a rare disease or something that's very common. In the hospital space, what the bill says is that the health for the fund will purchase directly from the hospital. Now, at the moment, that would not be possible in the public sector anyway, because the public sector hospitals don't have the necessary cost centers and finance structures and procurement plans and so forth to enable them to contract with anybody, really. They get a budget, and much of their functions are forced upon them from their provincial administrations as part of the current way in which government does things. So to move from that into a more autonomous environment is also complicated and will require quite a lot of investment in managerial skills and systems to enable the change that they can provide benefits that are paid for in this way, and that's how they get their budgets. It may be that there are foundation budgets or some kind of overheads budgets that are provided separately, but the intention is that's the direction we're going to move in. For the private sector, it's easier because at the moment, the medical schemes buy directly from them. But in the private sector, the hospital is a different client from the doctor who works in the hospital, and that is a different person from the laboratory, different from the physio, different from all the other players in the hospital. So there are many individual companies and people who are involved in the contracting. And over time, that model also needs to change so that there's more integrated service delivery within the primary care environment. The last thing I want to touch on before I stop and we'll rather take questions is that everything that we do requires the purchase of what we call health products. So medicines, diagnostics, treatment modalities, rehabilitation equipment, et cetera, et cetera. And those products need to be purchased by providers, but we need to use the buying power of the whole national health insurance to push those prices down. So what the bill does is it creates the space for what they call the Office of Health Products Procurement. That office will define the products, so a medicine or a diagnostic, and then fix a price to that product. And provided the product is registered with the regulator, which is SAHPRA, then anybody can buy from any supplier who is authorized and registered with SAHPRA to trade with one of those products. So what that would mean is a hospital which at the moment is required to buy on a big tender somewhere centrally or through a head office in some other city would now be allowed to purchase from a local supplier of those goods, but the price will be fixed. So we will benchmark, and we do it at the moment on about 120 products already. We will benchmark those products globally to check that we're not paying exorbitant prices, fix the prices for fixed periods, and then anybody can buy on those prices. That will obviously push the prices down, but what it does is it means that over time, when the artificial intelligence in the system, it makes it possible for us to understand where the products are being used, by whom, in what volumes, are there seasonal or other variations, and what is rare, what is rarely used. So sometimes those products might be biologicals like we would use in patients with hemophilia. They're extremely expensive, but there are only a handful of patients who get them. We will know where those products are being used, which individuals and families are affected, and we are able to accommodate that then in the way in which the budget allocation is made, so that we don't penalize the rest of the people living in that area for those few who are receiving very expensive care. Related to that is that we don't want to use products, and I use it in its broadest sense of the definition in the law, that are not shown to be effective or cost effective. So it may be that we would choose a slightly more expensive tablet or capsule because it's a single daily dose, because we know we'll get better compliance. Or it may be that we would choose something because it is 4 drugs or four different medications in one application, and it is easier to get compliance. So it's not necessarily so that the choice will be the cheapest. It will be the one that is within the clinical guideline, but that has the greatest economic impact in the way in which we provide healthcare. And there may be drugs that are excluded and have to be applied for. And we've seen, I mean, this happens now in both the public and the private sectors. So there will be mechanisms to deal with exceptions. But the aim is to use what we call health technology assessment. I'm sure you're all very familiar with this, to choose the most appropriate products and to have those on what is called the formulary in the bill. So we will have 30, 40,000 products in the formulary, and that's what would be used 99% of the time. And the only time we would work outside of that formulary is in exceptions where it's just totally not appropriate to use something in the formulary. So just to recap with one last statement, we're working towards what's called social solidarity and equity, where the only thing that matters is that if you have an illness or a condition that needs care, you get that care because of the need for the care, not because you've got money in your pocket or you live in some particular geographical location. It will not happen over time. We are not designing the system for next year's economy. We are designing it for generations to come. And as we implement over the next couple of years, we will have to take it carefully and piecemeal until in a properly sequenced event so that we get the benefits as we move along. I'm going to leave it at that, and I'll be very happy to take questions later. Thank you very much.
Thank you very, very much, Dr. Crisp. I do see some questions coming through. I just wanted to, we are a little bit ahead of schedule, so I thought maybe we could take some of your questions now, acknowledging how busy you are at the moment, and then let you off the line a little bit earlier than what we had initially intended. Would that be suitable?
Yeah, absolutely. If you don't mind doing that, that's fine with me.
Yeah, perfect. I think we are well timed to be able to do that. So, Gavin, I'm going to hand over to you, please, if you wouldn't mind handling the question section.
Yeah, morning, everybody. Thank you, Dr. Crisp. We've got 3 questions in the Q&A section. I don't know if you want me to read them to you, or you've got the ability to have a look at them.
Okay, I can see them as long as the rest of the. I'll read them out and then I'll try to answer.
All right, thank you.
Okay, thanks very much, Gavin. So what happens when the willingness to pay from the fund is significantly below the asking price for RD drugs, so rare diseases drugs? So let me take them one at a time. At the moment in the public service, rare diseases are treated. But obviously, there's a limitation and there's capping of care, and there is rationing of services. I think that happens even in wealthy countries. But what we try to do with a reform of the service is to get more for the same money by getting efficiencies. So a big efficiency, for instance, is to scrap 74 medical aids and have one, so that you're not paying 18% of the total cost of healthcare in the private sector purely on administration, no contribution whatsoever to patient care, 18%. And then that money becomes available for paying for rare diseases, drugs, and other diagnostics. And I mean, when we talk about drugs, let's call it products. But there may well be a point where it is just not cost effective for the nation. It's not cost effective for the individual. We know it happens. It's the most terrible thing when you're a doctor and you know you have to take choices like that. So I'm not going to try and create fairy tales here. There are times where there is rationing, And we see it from time to time, and that needs to be not arbitrary, but designed into proper clinical guidelines. And that means we need that our specialists and our clinicians who work in these environments to develop those guidelines. So for instance, as we sit here today, I will not qualify for dialysis in the public service if I needed it, because I'm over the age and I'm not regarded as a viable patient for a kidney transplant. That might be elevated to an older age once we have more money in the system, but at the moment that would be a fact. And it will happen that there will be patients where the system cannot and does not pay for the treatment. But that is not how we are planning the system. That is what happens outside of the default of the system. The default of the system is that rare diseases don't all have to cost such a fortune. And if you can push the prices down because you know there are more people and there are opportunities to negotiate those prices, then that is what we'll do in the NHI. So I don't think I need to add to that. I think I've explained. Will the fund reference bodies such as those found in oncology to establish which products or to use or fix a price? Okay, so the process that is described in the bill will require that there are technical reference committees of clinicians. So not people who are outside of the clinical environments and not administrators, but technical clinical reference people. We do have that at the moment, and we have a NEMLAC committee, National Essential Medicines Listing Committee. They have a large number of working groups on pediatrics, on TB, on HIV, on this and that and the next thing. And those reference groups are the ones who are looking at the medicines that are in the clinical guidelines. The clinical guidelines need to be drawn up by people who are in the clinical field. And between the two of them, they try to find where the treatment modalities are the most appropriate. As I said, we then, from time to time, new technologies become available, and one reassesses whether the technology that is in a clinical guideline is the one that is appropriate. So this is not a static process. The provisions in the bill are for both a benefits committee and a pricing committee that will advise the minister, but behind them, there will be, and as there are now, a wide range of clinical inputs that are received in order to determine what is going to be in the clinical guidelines and what in those clinical guidelines becomes part of the formulary. And the formulary may, for instance, include which diagnostic tests are done. So I'll use a non-rare disease example. Is it necessary to do ultrasounds on all pregnant women 4 times during pregnancy? The clinical guideline may say 3 would be at certain stages of gestation would be the maximum, and you would need to have some kind of abnormality detected or separate reason to do more than that. The system would then flag when more than 3 ultrasounds are done during pregnancy. I'm not a gynecologist, but if I use that as an example, just so that people can identify with it. Okay, the next question. While the robust plans are underway, what happens to a patient who are already diagnosed and waiting treatment in the public sector? Well, this is the inequity of the world at the moment, is that it depends where your lot falls. If you live in Cape Town, around the corner from Groot Schuur or Tygerberg, or if you live in Gauteng, down the road from Steve Biko, you got a better chance of getting healthcare than if you live in remote Northern Cape, Limpopo, Northwest. And that's not fair. So even now, what we are trying to do is to improve the referral system to make it more accessible for patients who live in other geographical areas. And the provinces do have budget constraints. It's a fact. And so what each one is doing is based on their own clinical guidelines and their own clinical committees. They are putting limits. So back to the example I gave earlier about renal dialysis. In some provinces, I may, with a scrape, still be young enough to get renal dialysis, although I doubt it. But in others, I definitely will not be, because they don't have the capacity to deal with people of that age. So I think we are in for a rough time for the next few years, where there's budget constraints in the public sector. And until such time as we are able to get better referral patterns, there will be geographical disadvantages. And we must just all do our best to help patients to work past those obstacles in the meantime. But again, it's not cloud cuckoo land. Things are tough out there. Next question: will funding for rare diseases or orphan drugs be a separate earmarked fund from the NHI budget itself? So the answer is no. NHI will not ring fence or separate earmark anything. What will happen is the decision on whether to include a treatment in the benefit of the fund or not. At the moment, the public sector includes everything, but then excludes certain things by, as I've said, by rationing, by putting caps on the guidelines of when one might qualify. The same thing happens in all DRGs, where certain conditions or treatment modalities are excluded. So in an orthopedic setting, it might be ideal to replace a joint, but an arthrodesis is a fraction of the price. So that may be that in certain settings, for certain age groups, the arthrodesis becomes the treatment of choice. That's not to say the country will not allow a person to insure themselves separately for that kind of outcome and pay for it separately. But the idea is not to ring fence budgets for specific diseases, whether it's HIV and TB, which are common, or whether it is some very rare genetic abnormality, or some other rare condition. It doesn't matter. We were not going to ring fence them. Next question is: will a national newborn screening program be considered as part of the new national health setup? The value, patient life, as well as monetary savings of having an early diagnosis for treatable rare diseases is definitely worth considering to include it. And my answer is that should be in place already. In fact, 30 years ago, when I was still in clinical practice, we did have screening programs. In fact, we had quite a good newborn screening program running in Limpopo way back. We had nurses who were specifically trained in newborn care, who were designated to every single hospital in the province, and I'm talking as far back as 1994, who were running newborn screening programs. They may not have picked up everything, but they were certainly able to pick up the bulk of the obvious milestone delays or strange looking deformities, facial features, and so forth. So that should be part of our standard primary healthcare program. And I'm actually disappointed it's not still there. So I absolutely agree with you, and that is something we would certainly push. Next question: rare diseases do not always have the same level of evidence when compared to common diseases. So when a certain threshold for evidence is set, rare diseases are often excluded. How should this be approached? So I'm certainly not the expert in the field that most of the people in this audience are, and so I can't answer the question to the level of detail that you would be able to answer. But there's always evidence. And what one wants to avoid is being completely random in taking decisions. And that is why we have or intend to set up even more of the clinical committees and setting clinical guidelines. So I've been part of the process for the past 2 years in developing the clinical guidelines for primary healthcare. It's a very rigorous process. It starts with just the high level framework of the clinical structure, if you like, and ends up with coding with just a number. But in between the beginning of the definition of that condition or even the parameters within that condition, there's a hugely rigorous process with lots of clinical consultation that takes place. And there's always evidence. Sometimes the evidence is soft, sometimes it's extremely hard and it can be verified, but there's hardly ever no evidence at all. And I think that that is taken into consideration by the clinical committees. And certainly now that I've been sitting in the Vaccine Ministerial Advisory Committee, where the evidence is changing all the time on COVID, I've seen the flexibility that is possible. And I don't see why we can't do that in the future. But clinicians are the best ones to be making those decisions, not people who are in administration like me. Thanks.
Dr. Chris, thank you very much. I think those were quite tough questions to ask in a very precise disease area. Just maybe to come to the end of your section, there's two questions I'd like to ask Dr. Helen Malherbe, just to ask her question. She's a panelist. So if you can just unmute yourself, Helen, you can maybe ask your question, and then I'll have a final question for you, Nicholas. Maybe just asking you to guide us on how this rare disease access initiative should engage with the NHI process and what you see we should be doing more of to highlight the plight of these patients and what more we can be doing to support diagnosis and treatment. Helen, over to you.
Hi, thanks, Gavin. Hi, Dr. Chris. Thanks for a great explanation of the NHI. I just wanted to ask, with regarding to the technical committees that are clinicians to actually make decisions around care and so on, where is the patient voice there to ensure the patient centricity and to also make use of the lay expertise? I mean, in many situations, you have such rare diseases that there is no evidence, there is no knowledge, and that the patients are the best source of that information. How does that feed in to the process? Thank you.
Yeah, I mean, obviously, as clinicians, our focus is on the patient, and that is where it ends. That's where the experience is felt, and that is where we want to make our impact. So you're absolutely right, but we rely on the clinicians who interface with the patients to be, I guess, the way that things are structured at the moment. Rather than having just the patients in the committee, you rely on the people who look after those patients, who are dealing with them, their general practitioners, their specialists, the people who are involved in the diagnosis and the treatment. It's not always ideal, and it may be that in every one of these committees we should get patients. Finding those patient representatives who can be objective enough to contribute is obviously a challenge, but I don't think it's something that we should exclude, and we should all work harder. I mean, that's the job of a clinician, to work harder to look after your patients all the time and to understand their conditions. You don't have to experience what they're experiencing to know that they have a challenge. And I must declare, maybe this is probably not a bad forum to do it. I have a relative in my family who has a rare disease, and I watch what they go through in the family, and we experience it as a family as well. The difficulties with getting payments and getting treatments and so forth, and the impact it has on their lives. So, at a personal level, I understand that. But I think somehow to have only patient committees would not work, and to have only clinician committees probably doesn't work either. But the interface between those is what we've got to strive towards, to make sure that organizations such as yours are a good sounding board and a mix of patients, carers, clinicians, nurses, others who work in the space and understand what it is that we need to provide in our clinical guidelines and ultimately in our care. I don't think it's a simple answer at all.
Thanks, Dr. Chris, for that. And maybe the final question comes back to what guidance would you give our grouping to take the initiative forward? We've developed a framework. We've tried to be broad and consultative. What more do you think we should be doing and engaging on the path of NHI?
Sure. Well, let's NHI aside, let's just talk about engaging with the health system generally. And it's going to go through transition, so you're going to be dealing with different and changing environment all the time. Personally, I think that clinicians and patients who lobby for patient care should be taken seriously, and they need to be included in whatever forums. Otherwise, I wouldn't have agreed to come and talk to this forum or listen to your inputs. The same is happening for TB, for hemophiliacs specifically, for people with orthopedic conditions, disabled people. So people who experience the health system very personally want to engage, and we need to find ways that we hear one another. It's not possible to sit every day, all day, and having like a desk inside the department that's dealing with every single condition. But we do need to rely on forums such as yours to hear patients, to understand what the conditions are, to be looking for the new treatment modalities, to be working with us on the health technology assessment, and engaging to make sure patients get the care that they require. At the end of the day, that's what there's no other purpose for a health system. So as national health insurance involves, it's a financing system. The system, the care system must care for the patients. But we need to find a way to reimburse those who provide that care. And sometimes it's the purchase of a medicine, and sometimes that medicine is an exorbitant price. And then when we go on the international market, we find we're paying double in South Africa than what other countries are paying. That's the National Health Insurance Fund's job, is to push those prices down and to get them to an acceptable level. Sometimes that's not possible, and it's just expensive all over, and we have to find ways to make sure that it's paid for within the budget. So my advice is, don't ever give up. Every one of us who represents patients must keep the advocacy for those patients and defend those patients and be the voice. You will not win every single battle. I struggle with this every day, all day, with the demands now, just with COVID at the moment, with people who want second doses and third doses and fourth doses and want this and want that and the next thing. And sometimes the answer is no. But frequently the answer is, yes, this is not a bad idea at all, but I hadn't thought of it yet. So the advice is keep in touch with whatever evolving structures there are, and don't lose the faith for those that you represent. Thanks.
Thanks, Dr. Crisp. I mean, that's really helpful, and I can hear the passion for the patients you have. So keep it up, keep the good fight, and you're doing the great job. Thank you very much. Kelly?
Thank you so much. I can echo Gavin's sentiments. I think you've given me a little bit of inspiration that we just need to keep pushing forward. Sometimes the road is long and hard, but I do feel that we are making progress. And thank you so much for giving us a detailed explanation of NHI and also just giving us some comfort in the intention around NHI. I think sometimes when you read about it from a policy perspective, the overall intent is not necessarily clear, and it is good to see that the emphasis is giving care to those who actually need it. So really, thank you, Dr. Crisp. We thank you for your time. I apologize for my change in appearance. True to form, our power has gone off. So I'm now logged on my phone, and I'm going to be introducing Dr. Mayette, who's going to be our next speaker. Dr. Mayette is the Deputy Director for the National Institute of Communicable Diseases, and is currently serving on the South African National Incident Management for COVID-19, as well as the African CDC Task Force for Coronavirus. Dr. Mayette is an occupational health physician and alumni of the Institute of Functional Medicine in the USA, with more than 38 years of experience in public health, with qualifications in tropical medicine and hygiene, public health, health service management, occupational health, and an MPhil in strategy from the Gordon Institute of Business Science. So we are in great company having her present today. She's also the immediate past chair of the Association of National Public Health Institute for Africa, and serves on the African CDC Expert Task Force as well. So we are going to be hearing from Dr. Mayette today on the input and proposals with regards to our surveillance in South Africa, which is obviously very, very important for us. And there were two quick poll questions that we were going to be to ask after Dr. Mayette's questions. So there are two poll questions coming up. And yeah, Dr. Mayette, sorry for the quite haphazard overview there, but over to you.
Thank you, Kelly. Thank you to the organizers and to Helen for inviting me. I recognize and want to acknowledge that at this point in time, your commitment to raising the profile of rare diseases despite the multiple competing priorities in the country. So thank you for doing that. What I'd like to do today is just contextualize the institutional framework. Next slide, please. Contextualize the institutional framework and look at some of the existing policies that exist. Look at some of the existing platforms and opportunities of where we can piggyback rare diseases in terms of the data collection and data management, and then look at a way forward. Trevor, could you advance the slide, please? The next one. Okay, so contextually, there are public health institutes globally that are responsible for rare disease surveillance. And these public health institutes are either national or supranational. They are science-based organizations that are often national agencies that act on behalf of the government, but provide evidence to improve protection and public health. And they are aligned with national priorities. And many of them are known in terms of the Netherlands, RIVM, China CDC, US CDC, and very recently, Africa CDC. And many of the Nordic countries have very, very strong rare disease surveillance activities that we could benchmark against our activities. Next slide, please. So the Africa Center for Disease Control was established post 2014 West Ebola outbreak, where heads of state got together and advised that we need a regional body to address special technical issues relating to outbreaks on the continent. So they were launched in January of 2017, and they often responding now to communicable disease, specifically outbreaks. But the plan is for them to improve surveillance across multiple areas. And the 5 blocks that are seen on the left of the side basically talk to surveillance and disease intelligence. And certainly this is an area where the rare disease surveillance falls in. The third component is in terms of laboratory systems and network, enabling surveillance, information systems. And the 5th one is the home of where we propose rare disease surveillance could rest in national public health institutes to conduct the surveillance and the research. Next slide, please. So coming closer to home, what has happened in South Africa? The National Public Health Institute establishment is a legal process that has been following a long and winding road. And I don't expect you to read that legislative process, but this was a Section 76 bill that involved provinces. And the president has signed this into law as Act 1 of 2020. It was the only act passed in 2020 on the 7th of August. There's regulations that need to be published, and then it can be enacted. Next slide. Once it's enacted, you can go to the next one. This is just the link for the act. Once it's enacted, the functions of this institute is to certainly support government in terms of conducting the research, evaluating the impact, but putting in the systems in place to monitor all diseases, to strengthen epidemiology and surveillance, to focus on the international regulations, but also to collaborate through cross-border collaborative networks and strengthen the advocacy, social mobilization, and partnerships for diseases. Next step. Next slide. And it can only do this, just go back one, please, Kevin. It can only do this with collaborative networks and partnerships. And certainly the circles, I've just included some of the elements, and it's not an exhaustive list. There are multiple stakeholders and partners and networks that underpin the success of a public health institute. And certainly you can plug the collaboration with the activities that you are doing of RDAI. Next one. So what are the divisions stipulated in the Act? It's communicable disease, non-communicable disease, and I've highlighted the non-communicable disease because this is an area where the rare disease framework could fit in. Occupational health and safety, cancer surveillance, another area, injury and violence prevention, environmental health, and of course the transversal functions. I highlight also environmental health because ideally we want to come to a point where we link environmental exposure and map that with disease burden. And so I think this is an opportunity for us to work towards establishing how there are overlaps, certainly cancer surveillance overlapping with environmental health surveillance. And one of the studies in the Netherlands showed that children who are exposed to injury and violence have a 30% greater chance of chronic diseases later on in life. And we need to start making these networks and overlaps. So although these are divisions, eventually from a surveillance and epidemiological perspective, we want to understand and unpack some of the causative attributes to some of the burden of rare disease. Next slide, please. So we're not starting on a green field. There are multiple existing policies, regulatory frameworks, and health information systems that exist across the country that do exist at the moment. They do require strengthening, and they do require elevating specific elements from this framework to support the rare diseases surveillance. Next slide. There's been a lot of work done on the health patient record system so that we have unique identifiers where we could track individuals from mother through to baby, through to the family genetic mapping tree, right through to the system of care, treatment, and support. Next one. So that's one project underway in terms of the health patient record system. There's also existing surveillance platforms that exist within the National Institute of Communicable Disease that are lab-based surveillance and clinic-based surveillance together with hospital surveillance activities. So if you just look at the DATCOF system, they've got all the private public hospitals on a surveillance system that was rapidly instituted for the COVID system. But certainly we could leverage on some of these activities that do exist. The National Health Laboratory Service tests 93 million tests per annum. This is a data source, a rich data source that we need to start tapping into in terms of links between rare disease, some of the genetic profiles, and I think one of the speakers will talk through that later. And there are already various surveillance systems for communicable disease in different clinics and hospitals. Go to the next slide, please. I want to discuss the Notifiable Medical Condition Surveillance System. And this is a tool with 55 medical conditions, largely relating to communicable disease, but there are also some non-communicable diseases, like, for example, organic phosphate poisoning, mercury poisoning that are included on this. But this is legally reportable by all clinicians in the country for these 55 medical conditions. And some of them are within 24 hours and some of them are long-term. And this is possibly an opportunity that we could leverage on to report rare diseases. Next one. I'm just going to flash through the next few slides to demonstrate some of the reporting for different diseases. So you could report on per facility, you could report on per district, you could report on down to granular level within facilities as a healthcare provider managing, for example, TB treatment adherence. Next slide. You can also measure impact. So, for example, this was an impact assessment of the introduction of rotavirus vaccine to prevent diarrhea in children. And you can see we've demonstrated for the department that after you've introduced the vaccine, there's been a 66% reduction in rotavirus diarrheal disease hospitalizations in the first 2 years of vaccine introduction. So it's not only the surveillance in terms of the quantum, but also in terms of interventions. Next slide. And then part of the reporting could be, for example, forecasting. Forecasting in terms of, this is one specifically for COVID, forecasting in terms of hospital admissions. Where do we expect the next wave? Where are the high burden areas? And certainly plow and direct resources to those areas that require interventions. Next slide. The cancer registry as well, you compare then in terms of the site, where is the site of the condition, which is most affected from a racial perspective, in which community, from a spatial perspective as well. And the next one. This is a malaria risk map, and I've cited this as courtesy of the Medical Research Council, but this is a plot map of all the areas where there is occurrence of malaria in the areas of the country. So we dot every area that identifies a low, a moderate, or a high risk malaria burden. And this informs whether you take prophylaxis or not. So it's certainly something that we could utilize as a similar mapping mechanism of where the rare diseases are possibly clustered in select areas and maybe identify specific exposures. Next slide. This is a slide, it's a rather busy slide, but it's something that I want to spend a little bit more time on, because this is a proposal of a framework for a surveillance plan for rare diseases. And the question that we need to ask ourselves, and unfortunately, I'm going to raise more questions than answers, but I think it's a good opportunity for us to debate and discuss a little bit more. The WHO talks through event-based surveillance versus indicator-based surveillance, where an event is, for example, a child born with a rare disease, but we may not know what that rare disease is at that time. So that would be, it's a little bit unstructured, it's undefined, as compared to indicator-based surveillance, where it's defined, it's structured, healthcare providers know what to report on. And the proposal is that we merge both an event-based and indicator-based solution as a hybrid solution, and we possibly could consider combining rare disease and congenital abnormalities in a data framework. Because if we're going to invest in setting up the system, if we want to plow resources, it may be good that we couple some of them. And this is an area for debate and for further discussion. And again, coming back to what Dr. Chris mentioned, what is the legislative or regulatory framework in which we're going to operate and report these conditions? And I think this is a debate that we need to further unpack and explore. Where's the best home for this surveillance? We need to then determine what is the priorities. What are the conditions that we want to include? Do we have an open list? How do we define them? When do your clinicians say this child meets the case definition for this condition? What is the coding for that? And I think these are defining the case definitions. And this is where we need the help of the clinicians involved in defining those and mapping those case definitions. What is the case report form going to include? What are the variables of the patient and the provider? And what are those additional indicators that we would require for that surveillance? Some of those could mean, for example, was the mom on any medication? what travel exposure did the mom have? What travel exposure did the child have? What are the environmental conditions? So all of these considerations need to be included in that element. And then we focus on the systems and the processes. How do we acquire this data, and what are the sources of data acquisition? It will certainly be from your clinicians, could be from your hospitals, from your primary healthcare clinics, from your NGOs, your CBOs, and faith-based organizations. But one of the things that we've not done very well is community and patient self-reporting. And I think this is, I've listed it there, and how do we explore communities notifying and reporting into the system that here is a rare condition. And then, of course, we need to define at what levels do we collect all of these things, and how do we feed then the laboratory data set into this broader system. And those processes and systems are already in place, but need to be tweaked. So in terms of the data collection tools, we need to then decide those tools. We need to decide on the ICD-11 coding, what's the processes of integration, the frequency of reporting, and of course, the cascade of information to those who need to know. And how does that feed back into the system, so everybody who's reported knows what and has access to information that determines the size, the scale, and the understanding of this of rare disease surveillance. And when we look at the system and the processes, we have to incorporate the data attributes. So we want to focus on the quality of data in terms of its completeness, the validity, its coherence and comparability. We want to look at the timeliness, how accessible and the usefulness and the user-friendliness of this data, but also the flexibility of the system to be able to add new rare diseases as they come on board and as they are identified. We want to deduplicate, so you obviously don't want the same child who goes to the audiologist and the cardiologist being reported multiple times. So we want to report patient-specific disease event. Then we need the analytical capacity to be able to interpret the data, analyze it, unpack it, and disseminate the data, visualize it in a way that everybody can understand. And in order for us to do this, we need to benchmark with what's happening in other countries. We need to do extensive literature reviews, have focus group discussions with our clinicians, with our patients, and do some observational studies. So look at those areas who are reporting. How are they reporting? What are they doing well? Can we learn from good practice? And we need to interview key informants to be able to inform this process. The technology is one limb and an important limb, but we have to review what's the existing technology, what's the capacity, connectivity issues. We have situations now where in the Western Cape, if you're on one side of the mountain, you can transmit data, and if you're on the other side of the mountain, you can't. What's the GIS platform that we're going to use to plot all of this data? And how do we integrate it with other systems, triangulate it with other systems that are in place? So if a child with a rare disease is more prone to develop other diseases, communicable diseases, non-communicable diseases, how do we triangulate that to match and include mortality data? How many of the children, the newborns, are actually with rare diseases are dying, and how do we triangulate that with mortality data? So not only with morbidity data. And then, of course, we need to look at the costing and the budget and logistics, the support and maintenance. So we document this data flow, this data process, everybody is understanding it. And do we want to put it in its own cloud, or do we want to have it on specific servers? So all of these technical and logistical areas need to be determined within the legislative framework, that we can't host data in clouds for in terms of legislative compliance with POPIA and so forth. And then we need to look at the monitoring and evaluation of the system. Are we reporting? Is the system reporting? Is it doing what it's designed to do? Is the frequency of the reports desirable? Is there appropriate feedback that is timeous? And are all the stakeholders, can they access this data? I've mentioned that. And then what's the consequence for people who don't report? How do we share case studies? How do we highlight the work of the clinicians who have detected rare conditions early and identified interventions? But all of this and this whole data framework is underpinned by the healthcare professional capacity building, training at undergraduate level, at postgraduate level, and in service as we evolve. And then communication. We need to have a robust communication plan and strategy that speaks to what we're doing, why we're doing it, the rationale for doing it, why it's important, and how we're going to model and utilize this information to model interventions that are going to benefit communities. Next slide, please. So what would be utopia? Certainly we want to have cost-effective maternal and newborn screening. Let's define the tools and let's formulate the training packages that we need now. That's an easy intervention that can be achieved very quickly without additional resources. Ideally, we want to move to precision public health. And this is really utopia, where we talk about balancing population health level data, managing risk with better, more personalized care in terms of precision medicine. And we'll need to focus on an area that South Africa will still need to move into in terms of your genomics, your phenomics, your epigenomics, and microbiomics, and all those omics listed in that circle. But I think we certainly need to have a vision of that ultimately where we want to be. I've spoken about matching to environmental exposure, and where we map the burden of disease very clearly, the accessibility of the data for both your patient and your provider, where ultimately we want to design a system that provides data for action. It provides data for intervention, for prevention, and for further research. And so I would like to, next slide please, acknowledge all the healthcare providers who are working in this space, the teams who are driving this agenda. Thank you. And most importantly, the patients who are living with rare disease. We acknowledge your contribution to these interventions. I thank you for your attention and happy to take any questions from the panel. Thank you.
Thank you, Dr. Mayette. I think there's 3 questions in the Q&A, 1 from Rajesh and 2 from Judy. I don't know if you can open it up, or would you like me to read the questions for you?
Okay, so Rajesh, your question is what is the funder response been like for notifiable diseases? This would indicate willingness for rare disease data sharing. So I'm going to use our experience for notifiable diseases. The funder response has been incredible. And it's been incredible at multiple levels. The funders have engaged with us through formulating data exchange transfer, for defining case definitions, for collaborating on identifying the ICD-10 coding system and moving to ICD-11 coding systems, We are working with many of the funders and the schemes in terms of data analytics, understanding data, understanding profiles and the burden of disease. So it's the funder responses and the partnership and collaboration is well established. I think we can always do more. In the COVID space, we are now working to do more and to strengthen the engagements. So I think this has been hugely beneficial. So the Board of Healthcare Funders has committed to support that. The individual schemes have committed to support the initiatives. And I think we can only do this as a collective. So we appreciate the support received so far, and we'd like to see it strengthened. So Judy has asked, who would you see as the host for such a framework? I think, Judy, the intention was that I presented the National Public Health Institute as the custodian and curator of communicable, non-communicable cancer registry, injury and violence. And so it could possibly be a host in the National Public Health Institute. It hasn't been legally constituted yet, but I think it is because it is enacted. We're just waiting for it to be promulgated and then finalized to implement. So I think, Judy, this would possibly be the host of the National Public Health Institute, but working with multiple stakeholders and multiple partners. Judy also asked, recognizing the implementation of POPI, what challenge do you foresee with regard to processing such a framework? I think the framework would need to consider all the aspects of the Act, of the POPI Act. And I think in terms of collecting individual patient and personal level data, that will have to be done within the framework of consenting of the patients, them understanding where the data is going, who has access to the data, what the data is being used for, what are the checks and balances in place to meet all the requirements of the POPI Act in terms of confidentiality, in terms of open access, in terms of where the data is stored. I think all the compliance listed in the Act will have to be embedded in the framework. It's the only way that we can manage the framework if we consider the POPI Act and all the other legislative frameworks in terms of patient confidentiality.
Thank you, Dr. Mayette. Final question from Dr. Mulherber. Helen?
Hi, thanks, Gavin, and thanks, Dr. Mayette, for a really good overview of surveillance and what NAPISA could potentially offer us. I'd just like to ask a question. I know we've debated it before, but the notifiable conditions in South Africa, which include cancer, because there is legislation that it is a notifiable condition, and it's pretty much the only NCD at the moment. Is that why it's kind of tackled separately in those themes that you presented? So it's not included under NCDs. And then my second question is, based on your overview earlier of the funder response, or the funder response to notifiable conditions, I think we again have to bring the issue on the table about making rare diseases or congenital anomalies, and whether we tackle them as one whole or independently. Should we consider, developing the regulations under NAPISA to ensure that they become a notifiable condition? Thanks.
Thanks, Helen, for the question. I think addressing your first question, there were many debates about whether cancer should be incorporated or kept separately out of the non-communicable disease space. And it was felt with the evolution of public health and the burden of disease, and certainly cancers becoming quite a prominent disease burden as with an aging population, that we should keep cancer separately. I think we haven't begun to address all the aspects of the cancer burden in the country as we should have. We need to take a deeper dive. And certainly it was felt that if you're going to start focusing on your non-communicable diseases of diabetes, hypertension, and cardiac conditions and others, you may lose focus and specific attention on cancers. So I think the Act speaks to different divisions. I mean, certainly we can share common platforms and we can share common reporting systems, but keeping them separate to ensure the focus, the attention, and the required detail for each of the different conditions. So that's why I think they were kept separate. And as I say, initially it wasn't, and then it was in the bill. It was incorporated and then it was separated. So I think we can live with that if we're going to pay specific attention and focus to that. In terms of the regulatory framework, so I think there are various options, and I think the regulatory framework for the notifiable medical conditions, we could include rare diseases, and the notifiable medical conditions regulatory framework is now being revised because it was felt that it didn't address all the aspects of the COVID response. So it is being revised at the moment. And when you look at additions to the regulations were designed to be flexible to incorporate other conditions. So if you look at just going back to the COVID response, we had novel respiratory diseases as a notifiable medical condition. We didn't have COVID-19 as a condition. And certainly Zika wasn't there, and MERS-CoV, and so we're going to have to constantly have a system that's flexible and adaptable to incorporate new conditions. The cancer registry, however, has got a separate reporting system and a separate regulatory framework for notification of the cancer registry. So you could have, for example, rare disease notifications or a rare disease regulatory framework. It could be a separate framework that is incorporated under an umbrella of surveillance activities for the country. So that's an option to be explored. Or alternatively, you could nest it within either the notifiable medical condition. You don't want to put it under cancer because this is it's not cancer. So you don't want to put it under there. But I do think there are also conditions in the country that are of public health significance that do not have to be under a notifiable medical condition surveillance system. So let's say let's take one that we have is reporting of all maternal deaths and pediatric deaths. All of these they are reportable. They are used to investigate, to do audits, to understand for the same reasons why the notifiable medical condition system has been designed for public health action. So you could put a framework of these are reportable conditions, and that speaks to the international health regulations of WHO, where they have the International Disease Surveillance Reporting Framework that speaks to notifiable. You have to report under these conditions, but these are the ones of importance for reporting for public health action. So I think there are multiple options, and we need to explore these, have further discussions, debate where they're best housed to ensure that all the requirements are met of a surveillance system. Okay,
great, thank you.
Thank you very, very much, Dr. Mayette. I think you have really given us some food for thought and very, very thought-provoking. and also given us some action points that I think we can absolutely take up and start investigating further. So thank you very, very much for your time. We're hugely appreciative. I did see a further question had come in from Dr. Amanda Crosser, but I think you have actually answered it when she was saying, should we consider separating? I think you have already provided feedback on the mechanisms in which we can use to take the surveillance and the notifications of rare diseases forward. So we are now going to move over to a very short break. We have allowed for 10 minutes. So if we can, please reconvene at 11:35. And there will be 2 very short poll questions coming up. There are multiple choice. They don't require a ton of mental thinking because we know you haven't had your coffee and you need it. So if you wouldn't mind, when you come back down to sit back down, if you could please answer those 2 poll questions and just give us a little bit of feedback on how things are going so far. Thanks, Chuck. We'll see you in 10. Well, everyone, thanks very much. Hope you guys have all had a very, very quick comfort break and made yourself some strong coffee, and that we're now ready to get back into it. We have just run that poll for those of you who have seen it. Thanks for participating. Interestingly, so 98%, there were 2 poll questions that were asked in this round. First being, do you believe rare disease patients currently have equitable access to the appropriate diagnosis, treatments, and healthcare services? And a 98% agreed that we did not. And the second question was, do you believe that a rare disease policy is required to ensure that rare disease patients have equitable access to diagnosis, treatments, and healthcare services in South Africa? And a resounding 100% agreed that that is absolutely what is necessary, which is good news for us at the Rare Disease Access Initiative, because obviously this is what we've been working on over the last 2 years. So it's really, really good to see that we were correct in our assessment that this is something that is absolutely needed to be done. So I'm going to move over to introducing our next speaker. Trevor, if you can remove the poll, the results, if you wouldn't mind. So our next speaker is...
It has been removed, Kelly. People just need to close it on their browser. Yeah.
Perfect, thanks. So our next speaker is Prof. Musa, who is a specialist consultant in medical genetics at Tygerberg Hospital and an associate professor of medical genetics at Stellenbosch. Prof. Musa was the first primary specialist in medical genetics to register with the HPCSA in 2012. And following her clinical training in medical genetics, she embarked on a PhD in molecular genetics in Germany. And her research focused on using the latest in genomic testing to discover novel genes and to end the diagnostic odyssey of patients and families with rare genetic diseases. So something that's obviously very, very passionate for us. She continued her research at Boston Children's Hospital and at Harvard Medical School, where she was exposed to the state-of-the-art technology and techniques in the field of human genetics and genomics. And in November 2019, she returned back to South Africa to take up the position as a consultant medical geneticist at Tygerberg Hospital and associate professor of medical geneticist at Stellenbosch University. As a clinical scientist, she is committed to providing the best care to her patients and is directing the research program on rare disease genomics in South Africa to further benefit all of us that are impacted by rare diseases. So, Prof. Musa, if I can hand over to you.
Thanks, Kelly. I'm just trying to share my screen. Give me 1 second. I always have 2 screens, so it's always a little bit of a delay. There we go. Can everybody see me and see the screen? I'm going to switch my camera off if you don't mind, just for the presentation, because we've had some internet issues this morning and I don't want it to impact that. Thank you. So thank you very much for the invitation to speak today. Rare disease is really close to my heart from my clinical point of view and from my research point of view. And the issue of coordinated care for rare diseases is something that not only we as South Africans have to grapple with, it's something that people have done overseas and are still grappling with overseas, but it's something that's really important if we are going to be able to serve the population of people with rare diseases in South Africa optimally. Just a few definitions to get us going. We all know what a rare disease is. It's a condition that affects less than 1 in 2,000 people in the population. And while individually rare, cumulatively, approximately 6 to 8% of the population is affected by a rare disease. And they span the spectrum of common rare diseases like cystic fibrosis or achondroplasia through to the ultra rare, some of which we would only, as medical geneticists, have seen 1 or 2 in our entire careers. And rare diseases are often called orphan diseases because they are historically, they've been ignored by all clinicians, researchers, government, the pharmaceutical industry, etc. And while, yes, they may be individually rare, it is vital to understand that cumulatively there are over 300 million people or so affected by rare diseases in the world. And we're almost at 4 million people or 4 million South Africans living with a rare disease. That's a significant proportion of the population. And we know that rare diseases are a public health issue. They're a global public health issue, but they haven't received as much attention in South Africa with regards to developing rare disease policies and frameworks And there's been very little in terms of legislation or rare disease plans and strategies in South Africa to be able to address the needs of people living with rare diseases. So I'd like to take you on a journey of some of the patients that I've seen, some of the families that we know. For some of them, this journey begins during pregnancy when the doctor finds that there's something not quite as expected in the pregnancy. For others, the joy of holding the newborn in their arms is overshadowed by whispers that there may be something out of the ordinary. For many, comparing little Timmy's physical features and his development to that of his twin brother Tommy brings people to ask the question, but why? And for many families, at the very latest, even the society will be asking why little Jyoti is so different from her friends. And this is a very scientific comparison between her and her ethnic, age, and sex match controls. The story I'm telling is of families affected by rare diseases across the world, and the journey that they are on is one of many. The first journey that they often take is one in search of a diagnosis. This is the very first step that everybody needs to be on, the very first step to get a diagnosis in order for everything else to happen afterwards. And unlike when you and I visit a GP with a particular complaint, we may get a diagnosis within a day and get a treatment, and the next day everything's right with the world again. For families with rare diseases, this journey to a diagnosis becomes an odyssey, a long drawn out odyssey punctuated by multiple tests, investigations, some painful, some invasive, many totally unnecessary. The conditions we know are very complex, often multisystemic, and therefore inherently complicated, and making the diagnosis everything but straightforward. Research overseas in Europe and America has shown that families consult an average of 8 to 10 medical specialists, and still the majority are left without a diagnosis. What about the very real scenario where misdiagnoses are made along the way? So instead of the diagnostic odyssey, many families find themselves on a misdiagnostic odyssey or the misdiagnosis highway. What of all the families who cannot even access a health facility to even get a simple blood test done? You can see that coordination is not the order of the day, that more disjointedness on even this first leg of the journey is obvious. So our work with families with rare diseases, many themes are highlighted. And I really like this picture by Carlos Bacha, which describes quite aptly the feelings of many individuals and families with rare diseases, this very real sense of being alone on a journey with an unknown destination. So he writes, long and lonely journey, my life. I've added long and lonely journey, my life with a rare disease. And there are literally millions of people on this odyssey, and it is our collective duty to end this odyssey for them as the very first step. I know that I've depicted the diagnosis as the end of the road, but actually the diagnosis is not the end. In fact, it is only the beginning of what will become many other actual life journeys that the families will need to navigate. It's an important start, a necessary tool for accurate prognosis, for appropriate management, and importantly also for accurate genetic counseling. Without a diagnosis, we are literally operating with minimal information, treating only symptomatically and not serving the patient optimally. A diagnosis as the first step is an important impetus for being able to judge prognosis, for improving management, but also for accurate risk assessment, prenatal diagnosis, etc. It's also a driving force for moving science forward as an impetus for further and deeper study to have an improved understanding of physiological and pathophysiological mechanisms underlying both health and disease. And ultimately, you cannot treat what you didn't diagnose, and improved treatments lead to improved quality of life. I'm mentioning these stats only because they are what we need to keep in our minds in order for us to know what our priorities are. Behind every percentage point on the slide, you have to keep in mind that there are actual people, actual children, actual families, actual people affected by rare diseases. We've set ourselves goals like the UN Sustainable Development Goals. They cannot be achieved without giving attention to rare diseases. Under 5 mortality cannot be addressed without attention to rare diseases. So why do we medical geneticists care about rare diseases? And it's quite obvious because the overwhelming majority of them are genetic in origin. And there are so many of them. Now, the slide is a little outdated. It says over 6,000 distinct rare diseases, but actually there are close to maybe 8,000 today. And we are, as medical geneticists, experts in diagnosis and act as the stewards of patient management and care. So in our team, we don't work in isolation. The medical geneticist is very much part of a team. We're very lucky in South Africa to have genetic counselors who work alongside us in the clinic. And our clinical activities are supported by the laboratory and the scientists on the other side, including bioinformaticians, in order for us to be able to provide diagnoses and accurate diagnoses, which we can feed back to patients. Obviously, we also work with various medical specialties because rare diseases can present at any age. They can also present with any symptom from any part of the body. It's very important for us also to communicate with community services so that things are not only done within the tertiary center, but are translated into improved access in the community. We are very happy, and our work cannot be done without the support of the patient and parent support groups. And as advocates for our patients, we also have to interact with government, the hospital, the Department of Health, in order to improve access for them. It's very important to have an idea of what is happening in South Africa and how disjointed things are in order for us to be able to move to what we would like to see as coordinated care for rare diseases in South Africa. And so just an idea of what medical genetics is like in South Africa, we have 5 departments. Or 5 medical genetics departments with approximately 15 medical geneticists who work across private and public space, located in Gauteng, Western Cape, and 1 center in KwaZulu-Natal. So the most obvious thing about this picture is that 6 out of the 9 provinces are without access to medical genetics. There's a single medical geneticist who is responsible for the services in the entire whole of KwaZulu-Natal. And you can imagine that that's not sufficient for the needs of the rare disease communities, not only within the provinces where there are services, but especially also for those who are located in provinces where they do not have access to a medical geneticist or medical genetics services. So while we want to work towards coordinated care, it's very important to know how things are right now, that they are very disjointed, that they're very fragmented. For most of our patients, they face considerable barriers in terms of access to appropriate care, delayed diagnoses, limited or non-existent treatment options, etc. There are huge inequalities, not only between private healthcare and public service, but between hospital and hospital, province to province, clinic to clinic. Like I said, there's no access at all in 6 of the provinces, 6 of our 9 provinces. But even within a province, there's still trouble with access to the hospital, even if somebody is located in Gauteng or the Western Cape or KwaZulu-Natal. Families face many challenges with coming to hospitals, so things are not coordinated. They have multiple appointments per month. There's little communication between the specialties. There are few appropriate diagnostic tests available locally. And they face problems with access when moving, not only from hospital to hospital or province to province, but also when transitioning from pediatric care into adult care. And so many other challenges are also faced in terms of funding for research, in terms of access to treatment, in terms of access to clinical trials. There's no standardized electronic health record that is available across provinces or across hospitals. And we have very few registries for rare diseases. And I think all of this fits in nicely into what we need is a coordinated policy on rare diseases in order to improve at least some of these challenges that we face. And we're 10, 12 years behind the rest of the world in terms of making this a priority. Rare diseases in the center as a priority has been recognized, for example, in the European Union way back in 2009. And they've decided on an action plan how to leverage the expertise that they have in a way which is most beneficial to the rare disease community. This included establishment of centers for rare diseases or expert centers. They've got rare disease registries that are Europe-wide, and newly established European reference networks. These all feed into legislation, it feeds into coordination, not only across countries, but across the whole of Europe, potentially. It improves monitoring for rare diseases, and it improves communication and networking for the benefit of the rare disease community and population. There's no such policy in South Africa yet, but I think that this is something that we need to recognize as a priority in order for us to be able to move forward and improve not only access, but treatment, management, care, and to get everything coordinated. So I like the idea of a center of excellence where the patient is at the center and everybody working together, networking, available to be able to benefit the patient who is, after all, the person that we are there to care for, the one who we are there to look after, to help, to manage, to treat, to improve their quality of life. And this really involves so many players, from the doctors that are involved to the laboratories that need to be able to offer the appropriate diagnostics, to other specialists, optimally working in either multidisciplinary teams or multidisciplinary clinics, so that patients don't come back 3, 4, 5 times a month, but come to one clinic and see everybody that they need to see. We definitely need the involvement of support groups and other community organizations. There needs to be improved access to research, which includes clinical trials and therapies, and more teaching and training, not only on the clinical side, but on the science side of things, in order to have a better idea, not only about which rare diseases are common in South Africa, which rare diseases are available for us to study or need us to study in further detail, and what a GP, for example, or a medical student needs to be taught as far as rare diseases in order to be able to, when they are out in the community, be able to recognize that this patient is a potential rare disease patient. And I'm talking about medical students, but this goes across healthcare workers, across community workers, potentially, in order for us to be able to get to where we need to be. The concept of a center for excellence or center of excellence is that there's continuity of care with comprehensive services and research all under the same roof, potentially. It improves collaboration. We need a lot more collaboration across centers, but also towards the community. We need policy which can help raise awareness, but also legislation, with regards to data sharing or the establishment of registries. All of this feeds into an improved healthcare and equitable access for people with rare diseases, which ultimately our goal is to improve their quality of life. And no one person or one group or one center can do this. There needs to be real political will for us to be able to get all of this coordinated on a national level. And so I really think that a rare disease national policy is definitely needed. It takes, we need to recognize that rare diseases needs to be placed as a priority for our national health. There needs to be support for medical genetics education and training all the way through and throughout, not only medical school, but other healthcare workers, other community workers, how to recognize a person with a possible rare disease. There needs to be proper referral pathways so that patients are referred in a timeliest way, in a timeliest manner, and in a way that is easiest for them to be able to access all the services that they need. More support for medical genetics, more support for geneticists and genetic counselors and other specialties. So we're training people, but we don't have the capacity to absorb them after they trained. And yet there are 6 provinces that don't have a single medical geneticist or a genetic counselor working. I think more support for centers of excellence, for example, would be something that we should definitely look at, because these diseases and disorders are inherently complicated and need specialist care. But also support for mobile health solutions. So maybe there's a way for us to include people in the rural areas via mobile health as a first step. There's a definite need for us to implement the latest in diagnostic tools and have multidisciplinary teams, more support for funding and funding for research, for example, and the policies from government all the way down to to support the rare disease community. You know, things are disjointed, things are fragmented at the moment. I think that a rare disease national policy will help us to at least ensure buy-in from all the stakeholders to recognize this as a priority and for us to be able to start to address some of the challenges that we face. So I know that you know, it's a huge undertaking to move from disjointed, fragmented care to coordinated care, but we need to start somewhere. A policy will help us to align our objectives, to align our vision and our mission, and let's work together to see how we can move from where we are today to providing the best care, the best management to improve the life of people with rare diseases living in South Africa. Please contact me. Thank you very much for the opportunity to talk. And I'm happy to take any questions.
Thank you, Prof. I think it was really, really good. In terms of a burning question that we have, we've got two. One is from Judy. She's saying, in addition to policy development, how do we mobilize efforts to see these centers of excellence come to life? I think there's lots of mention about centers of excellence, and you're living it in the real world. Maybe you can guide us on what we should be doing better to make these centers of excellence work.
So there needs to be buy-in not only from the people working in the center of excellence or the potential center of excellence, but there needs to be buy-in from the hospital, from the university, from the Department of Health, locally as well as nationally, in order to support these very important centers. We know that rare diseases are complicated conditions most of the time and that they need specialist care. Having everything under one roof is one way in which we can support them to the best of our abilities. This includes, you know, if somebody's living in 200 kilometers away from the center, this includes getting them the transport to the hospital. This includes having all the resources that we need for their stay in hospital, for example, and then going back to the community, that they're not left again isolated in the community. So I think, you know, the center of excellence can be the center, but it also needs resources built around it. And that requires not only academic hospitals or tertiary hospital input, it requires buy-in from everybody, from the community, the government, the local Department of Health as well. So this is a conversation that's ongoing. This is a conversation that needs to be ongoing for us to figure out a way how we can leverage what's available at the moment, and then just reframe them, perhaps, the resources that we have in order to support these centers of excellence, or whatever you want to call them, a center for rare diseases, to be able to support the population with rare diseases.
All right, thanks for that, Prof. The final question from Carol Lynn. She's saying, how can NPOs or support groups for rare diseases get involved to help more? Now, I think that's a very broad question, but maybe you've got some thoughts from your perspective, Prof.
I think so we can't do our work without support groups. You are on the ground, you know the families, you know who's been seen where, you know who needs access to something, you know what the needs are of the actual people affected by rare diseases. And so, you know, more channels of communication need to be open between the doctors or the healthcare workers working with people with rare diseases and actual support groups who support them, you know, in the community. And I cannot work without working together, for example, with our brittle bones disease, Brittle Bones South Africa, for example. We have a very good working relationship where they refer patients to us. We go back into the community, into the support group, you know, helping with more education, helping to answer questions. Support groups themselves have a huge role to play in giving support to people with rare diseases. There's only so much I, as a medical geneticist, can say and advise, but it's a different kind of advice that you get from another mom who has a baby with the same condition that your child has. And so I think more communication is something that's very important. And we're always, I'm not only talking for myself, I'm talking about every geneticist and every healthcare worker would be very happy to have more communication between us and the support groups.
Thank you very much. Professor, I see that there is one question that's come through on the chat function. Do you envisage a clinical center of excellence in each province is necessary in order to improve, obviously, access?
I think that we definitely need genetics in every province. Just due to, South Africa is a huge place. We don't want people, having to be transported for hours and hours to the nearest center. There are universities in every province. There should be a medical genetics department in every province. There should be a center of excellence for rare diseases in every province. We are training people that can take up this challenge. We need to be able to provide them with the jobs, the positions, and the support for them to be able to do the work that they've been trained for.
I couldn't agree more. I see another question's come through from Zeralda asking, do you have a facility readiness assessment or defined criteria that the COE should meet that you can share?
I don't have one, but we have been looking at this. I've worked in Germany for a long time. They have a framework that they use to be able to define what a facility needs to be in order to qualify as a center of excellence. And we're looking at how we can translate that to make it something that is applicable to South Africa.
Okay, that would be great. Thank you so very much for your absolutely insightful. I mean, I think you've touched so many points that we know to be true already. And I can't stress your comments around the capacity building enough. I mean, we see, one geneticist in the whole of KZN for 11 million people. I mean, it's an absurd amount of workload, and you cannot. And there's only 3 provinces in the country. So we're obviously doing everything that we can, but I think it's always something to bear in mind from a stakeholder perspective that if anyone's looking to implement projects in a private-public health partnership, genetic services is probably a really, really great way to do that because it's absolutely needed. So thank you so very much. We're going to move over now to Katrine Fourie, who is a genetic counselling manager at the NHLS at WITS. And Katrine has completed her genetic counselling training through the University of Cape Town and Stellenbosch University. She joined the WITS NHLS team back in 2019, where she currently works as the genetic counselling manager and lecturer. Katrine consults in both the private and public healthcare systems in Joburg with families who either have or are at risk of genetic conditions, and she's also involved in various research projects and postgraduate teaching within the Division of Human Genetics. And while Katrine's getting ready, I just, from a personal perspective, genetic counselling is something that we are so hugely passionate about at Rare Diseases South Africa, because the value to these patients is it's indescribable, and I can speak from personal experience. So I'm always hugely grateful to all the genetic counsellors that we have there, because I really do think that they help patients navigate a very, very difficult journey and really give us access to the information that we want to hear as patients. So Katrine, thanks. Over to you.
Thanks, Kelly. Can I just confirm that you can see my slides and you can hear me clearly and properly?
You are quite faint from a volume perspective, but we can see your slides.
And you're actually very soft. I suspect that there's a microphone in that earpiece of yours, and maybe you need to just move that up a little.
Hang on. Is that any better?
Hardly, no. I'm afraid.
All right.
Hang on.
How about that?
Much better.
I do tend to present
Great.
without microphone, without earpieces. So just shout if it does get lost again. Okay, thanks, Kelly. So yeah, I'll be talking quickly about diagnosing rare diseases, obviously from a genetic perspective, but as we've heard, vast majority of rare diseases tend to be genetic. So that's very appropriate. I'll be looking quickly at the types of genetic conditions, why it's important to have a diagnosis, and then look at the various genetic testing, some of the barriers that we find to diagnosing, and then also do a quick case study if we have time. So the previous presenter, I think, did such a nice job on the diagnostic odyssey that I'm not going to spend a lot of time on it. I think she raised all of the important points. But obviously, just to add that this extended amount of time that it takes to get from identifying a problem and sort of naming the problem does take a toll on the patient, the families, everyone involved. And that can be psychological, emotional, financial, physical, what have you. So it's obviously very important for us to get to that end of the odyssey, to actually have a diagnosis and a name for a condition. But unfortunately, that's not so easy. And one of the reasons for that is that we obviously have a lot of genetic conditions, a lot of types of genetic conditions. So very sort of briefly, they can be divided into things like single gene conditions, which is a mutation in a single gene, triplet repeat conditions. Single gene conditions then also are autosomal or sex-linked. And then you also have stuff like chromosomal problems, numerical, which is your more common genetic things, I suppose, like Down syndrome, Turner syndrome, but then also other chromosomal structural conditions. And the reason I've got this up is I think it highlights the difficulty. I think a lot of people who don't know a lot about genetics feel, why is it so hard to identify? Surely you've got a problem, you do a test, you find the answer. But this is why that is such a difficult thing to do in many cases, because there are just so many places to start looking. And as we've already also seen, the diagnosis really is very important. It can guide the management, so actually inform treatment if there are other investigations that need to be done. Something that's very important is it can clarify your recurrence risk. So what is the chance of having another affected child, for example, or another family member affected? This in turn can often inform your reproductive decisions. So taking on things like prenatal testing or pre-implantation genetic diagnosis in order to prevent another child with the same condition, for example, or even in certain cases to prevent disease progression where early intervention can make a difference. And then obviously also there's a vast amount of psychosocial things involved with getting a diagnosis, naming what you're dealing with, taking away that uncertainty for the patient and for the family members. So incredibly, incredibly important to find a diagnosis. So when we look at genetic testing, which obviously is where most of these diagnoses come from, and it's a very broad subject, and I've tried to hit all the major points. It can generally be sort of divided into screening tests and diagnostic tests. So for a screening test, it determines and points out people who are at an increased risk of developing a condition. It doesn't give a diagnosis, but it sort of guides your diagnostic testing. So if a baby, for example, screens high risk for cystic fibrosis, they would then go on to do molecular CF testing and get a diagnosis. So it sort of streamlines things so that you don't have to do diagnostic testing on everyone without knowing if they actually are at risk. Then your diagnostic testing is obviously the sort of next step in those cases where screening has identified a high risk, and it then gives you a definite diagnosis, often in a symptomatic patient, but not always. And diagnostic genetic testing is done pretty much at all stages of life, pregnancy, pediatric, adult. So it's always involved. Then this is an example of the types of testing that is done. I'm going to look at this in more detail in subsequent slides, but you can see that, again, for the screening, generally we have things like newborn screening, carrier screening, non-invasive prenatal screening, and the diagnostic side are your sort of cytogenetic tests, molecular tests, and so on. There are obviously, unfortunately, a lot of barriers to getting these diagnoses, and I've sort of grouped them roughly under limited expertise, the cost of testing, and the accessibility of testing. So the first would be the limited expertise in South Africa. So this was also touched on in the previous presentation, we've got roughly, and these are approximate numbers, it might not be completely correct, we've got roughly 30 practicing genetic counselors in South Africa. We've got roughly 14 practicing medical geneticists. And just to make sure that everyone knows the difference between those two, a medical geneticist is obviously a medical doctor that has specialized in genetics. Genetic counselors are people who have a professional master's degree in genetic counseling and work with medical geneticists to provide a clinical service to patients. So discussing information about the condition, inheritance patterns, identifying at-risk individuals, further testing, and so on. So we often work very closely together. It's recommended in South Africa that there should be around 320 genetic counselors and 80 medical geneticists. So vastly, vastly understaffed, under whatever you want to call it. And this is a very similar slide to what Prof. Musa had before, which I love, because you can see that even though we are from completely different teams, different provinces, this is an issue for everyone in clinical genetics, is the fact that our genetic services are so limited. We don't have them available in all of the provinces. And even in the places where they are available, as Kelly has mentioned, one medical geneticist for the entirety of KwaZulu-Natal is a big problem. And the type of service can also differ between the different provinces. So what I mean is what you can access in the public sector in the Western Cape can sometimes be different from what you can access in the public sector in Gauteng. So there's a big inequality based on where you are. You know, as it's been mentioned, if you're across the road from Groote Schuur or Baragwana Hospital, your access is going to be better than if you are in the Northern Cape. And unfortunately, obviously in our particular setup, telegenetics is not always a feasible option. So we obviously know this now because of COVID. We've all tried to do as much telehealth as is possible. And you'll see many other countries have done that very successfully in genetics. But the problem, obviously, in South Africa is around things like access to internet, so that you can do a Zoom consult with a patient, or even things like having a cell phone that is properly charged for our state patients. So there's a lot of issues like that. So unfortunately, reaching someone in Limpopo to do a telegenetic consult is not always as feasible as we would like it to be. And obviously we want these experts because they can hopefully shorten that diagnostic odyssey quite significantly. So for example, an expert can choose the right test. And you can see that this is quite an involved table of when do you choose which test. And even this is very oversimplified. So it takes a lot of clinical thought and input to choose the correct test. And we obviously want that to avoid these kinds of things. So this is a request that came through our unit a little while ago. And you can see that this doctor has asked for testing of, I think, 6 different conditions that are in no way clinically related, and asked for 6 different genetic tests that are in no way actually related. And it's not in any way the fault of the requesting doctor. It's probably out of a sort of sheer desperation of finding something and having no idea where to sort of aim the test and where to focus it. And this is obviously where your medical geneticists are invaluable, who can do a clinical assessment, take into account other types of testing, and aim the test in the right direction, so that we don't end up with these requests that really cannot be processed in any way. Experts can also obviously interpret the results. I think there was a time way back when where what most people, healthcare workers, needed to know about genetics was sort of the amount of chromosomes that a person needs to have. So they'd be able to see that this person has got Down syndrome because there are an incorrect amount of chromosomes. But we've come such a long way from that. We now have things like microarray testing, MLPA testing, multi-gene panel testing, and things become so much more complicated than what I think it used to be. So it's getting harder and harder to assume and expect that people in other fields, so for example, that a pediatrician would know everything there is to know about pediatric genetics, or that an obstetrician knows everything there is to know about prenatal genetics, because it's just become such a big, ever-changing field that you really can't expect them to keep up with all of that and to know all of these things. And then additionally, the training, obviously, of genetics, we tend to be a slightly overlooked area, is not always what we want it to be. So not often, but we definitely do have instances where a result is misinterpreted by a non-genetic healthcare worker, and that can lead to all kinds of other problems. Then there are issues around cost and accessibility, and I've sort of kept these two together because the cost is what makes the testing inaccessible to large parts of the country. And I mean, to keep in mind here that the majority, I think it's something like 70% of our population makes use of the public healthcare system. So if we look more specifically at the genetic testing that I mentioned before, we have things like screening, which very roughly in a genetics point of view includes newborn screening, reproductive carrier screening, and non-invasive prenatal testing. So just to clarify, newborn screening here would mean specifically testing, so biochemical blood tests to identify babies who are at risk of having certain metabolic conditions, things like cystic fibrosis, with the idea of early intervention, then making the outcome a lot better. Carrier screening is identifying couples who are at risk of having a child affected with a genetic condition. Non-invasive prenatal screening is a way of identifying pregnancies that are at high risk of certain chromosomal conditions usually. However, the cost involved here is high. So newborn screening, and just a disclaimer, these are all sort of approximate costs because it does sort of depend on which lab you use, things like that, but it's more or less accurate. So newborn screening, you can see, is roughly 6,000, the same for non-invasive prenatal screening. The reproductive carrier screening I've got up there in dollars, simply because that is usually where we access it in our service. And I'll give an example of that just now. And these things are not always covered by medical aid. So it's fairly obvious, I would think, just from the cost, that this is generally not available in our public sectors. So our public patients can't access newborn screening or prenatal, non-invasive prenatal screening. They can't access reproductive carrier screening without a family history to inform that carrier screening. So this is really available only to a very small percentage of our population. And even then, it usually is covered out of their own pocket. So it also depends on whether the patient or the couple actually has the funds to pay for this testing themselves. So this is an example of the use of newborn screening and what we generally tend to do. So this, again, is based on my experience with our private patients. It might be different in, for example, the Western Cape, but not a lot. So let's say, for example, you've got a couple planning a pregnancy. They've got no family history of note, so nothing specific that you want to test for, but they would like to do reproductive carrier screening to just see if there is any genetic conditions that they are at risk for. And what I want to highlight with these examples is the problem also of accessing local testing versus international testing. So in this case, what we would have available locally, sorry, this is frozen. While that sorts itself out, I'll continue my story. Generally, what we have available locally is focused at a specific population group. So we've got testing for the Ashkenazi Jewish population. And the reason for that is we know that they are generally a high-risk population for a number of genetic conditions. So that can be accessed as a panel. There we go. And is roughly 9,000 per person. So if you think about that as a couple, you'd need to do both, and it's only really useful in this high-risk population. So for a couple who are not of Ashkenazi Jewish descent, this testing really has very little value. What we often offer our patients instead is international testing, which we access through a lab in America generally, who tests for up to 300 genetic conditions at a cost of roughly 5,300 per couple. So you can see that that is the very obvious choice to do. Again, that cost is out of pocket though, because medical aids do not cover testing that is not done locally, which is obviously a big problem in these kinds of examples. Then moving on to things like diagnostic testing. So that would be microarray, which is a way of looking at chromosomes at a very deep level, single gene testing for specific conditions, targeted panels. So that would be a lot of genes that is related to the same condition done at the same time. And then whole exome sequencing, looking at the entire exome of an individual. Roughly, again, prices for this would be, say, 9,000 for the microarray, more or less 2,000 per single gene. The panels get more expensive, and the whole exome sequencing is incredibly expensive. And also, just to clarify that more or less 18,000 for a whole exome is for your patient only. But ideally, what you would like to do is do a patient with their parents, which then obviously becomes much more expensive again. So again, not surprisingly, not all of this is available to our public state patients. Exome sequencing, certainly not at all, unless they access it through a research project, which sometimes happens. And then targeted panels, again, sometimes, often mostly through research, but generally this is not available to everyone in the state. We do have microarray testing available mostly, and single gene testing, but then obviously you would have to know exactly which gene you would like to test. This is another nice example of problems we have with testing is, for example, having a family with what looks like an underlying cancer syndrome, but not clearly caused by a single gene, so you don't know where to start looking. So you want to do a targeted gene panel as your best option. For example, our local testing would be roughly 10,000 Rand, and let's say 9 genes that are related to breast cancer. So this is what we access locally, and that can be covered by medical aid for our private patients again, but not always. On the other side of that is, again, the international testing, which we do at a cost of roughly 3,800. They can test 37 genes related to breast cancer, so a lot more sort of bang for your buck, and also offer something like free family testing. So there are times where you can test an entire family once you've identified a mutation for the same price. And you can again see why there's a very obvious choice of testing, but with the same problem that it's not covered by medical aid. So it's out of the patient's own pocket, which obviously has those problems related to it. All right, very quickly, I'm going to run through a case study, and this is a theoretical case, but based on, real events regarding cystic fibrosis. So cystic fibrosis is one of the more common recessive conditions. So it's a more common rare condition, if you can put it that way. It affects mainly the lungs, pancreas, liver, intestines, and involves chronic sort of treatment. So antibiotics, pancreatic enzyme supplement, bronchodilators, steroids, physiotherapy, and so forth and so forth. And at a very extreme, it can also require a lung transplant. So think about the cost involved in treating this person. Then the case is a young woman that is affected with CF herself, private patient, currently pregnant. The partner is found to be a carrier of cystic fibrosis, which means there's a 50% chance for the child to have the same condition. So options for that couple would be prenatal testing. to confirm if the fetus is affected or unaffected. Should the fetus be affected, you can do things like early intervention, which slightly improves the outcome, or a termination of pregnancy, which is what this couple would like to opt for. However, prenatal testing is very expensive and they can't afford the testing, so they ultimately choose to continue with the pregnancy. And just the thinking about this cost versus the cost of treating someone with this condition, I think is a very good highlight of some of the problems we have in diagnosing and what we can access and what we can't access, because it's, in certain cases, is just so illogical, it almost breaks your heart. And that's that. Thank you very much.
Thank you very, very much, Katrine. I think your that case study there really just highlighted some of the issues that we know exist in the world. I think hopefully that, you know, if ever there's a point to come across with regards to the importance of being able to screen these patients, particularly prenatal testing, that there is actually a cost-saving benefit to it. In the interest of time, I'm going to ask, there was one question that had come through with regards to testing of Gaucher disease, etc. If I can ask that maybe you can submit type answers to them, to the panelists, in the interest of time. And then if we have time at the end of Helen's discussion, we can move back and discuss them in detail again. So our next speaker is Dr. Helen Malherbe, who is we're very, very lucky to have her as our Honorary Director of Research at Rare Diseases South Africa. Helen is a postdoctoral research scholar at the University of KZN and also assists with research in an honorary capacity at Rare Diseases South Africa. Helen's involvement in the congenital disorders and rare disease community began in 2004 when she lost her first baby to trisomy 18, and soon after established a contact point for families in South Africa affected by the same condition, and she still runs that today. After starting out as a plant geneticist, Helen was conferred her PhD in April 2017 at UKZN, entitled An Investigation into the Renewed Need for Care and Prevention of Congenital Disorders in South Africa, from which 11 peer-reviewed papers have been published to date. So Helen is going to be discussing a collaborative research for us today. And Helen, I'm going to hand over to you.
Thanks, Kelly. Sorry, I'm just, there we go. Great, thanks very much, Kelly. Afternoon, everybody. I know this is the graveyard shift. It's going to be relatively short and sweet, and I want to really focus within the context of a rare disease policy for South Africa and how collaborative research looks within that. So I'm quickly going to go through the global context very briefly because it's been covered already. I'm going to give an example of definitions, types of research, the pros and cons or the benefits and challenges of collaborative research for rare diseases. What does collaborative research look like? Collaborative and some examples, and then just rounding it off with coming back to the SDGs and leaving no child behind. So as already outlined by many of the speakers, I actually just want to give that global context for rare diseases. So we know that more than 350 million people globally are affected by a rare disease. We know that only 5% of those have an FDA-approved drug. 50% of those affected by rare diseases are children, and about 30% of those children with rare diseases won't live to see their 5th birthday. We're somewhere between 7 and 8,000 rare diseases that have been identified and characterized, and we know that the majority of them are genetic in cause. And so that's significant because most rare diseases are therefore considered as congenital disorders, and in terms of the terminology that's used. So the quality of life for people with rare diseases is a huge issue, and it's not always related or dependent on the severity of the rare disease, but it is dependent on the availability of that treatment and diagnosis, the health systems and services that are available to them, what support in the social context is available, and access to supportive care and psychosocial support. And in South Africa, it's actually somewhere between 3.2 and 4.3 million South Africans that we now estimate are impacted by rare diseases. So this is a significant burden of disease as a collective. So I thought it would be quite nice, because this definition has come up a few times, and it's something that we've been considering within the Rare Disease Access Initiative. There isn't an official definition for rare diseases in South Africa. And as many of you will already know, different regions, different countries actually use different definitions. And what we have decided through collaborative research with one another and working together, we did a little literature review on the evidence base for the different types of the different definitions. And for now, we would like to suggest that we recommend that we use the definition of a rare disease, an individual rare disease, being a condition that affects less than 1 in 2,000 people. So as a ratio, that works out to 50 per 1,000 of the population. And this is the same definition that's used in the European Union. And there is a large amount of robust research that's been done in the European Union around this definition. And we summarized everything in terms of ratios and how many people are affected. So as an individual rare disease, we define as affecting 1 in 2,000 people, which in terms of the South African population means it's a disease that affects just under 30,000 people. But obviously the more rare conditions will affect less than that. But remember, this is one rare disease. So as a collective, that is what adds up to somewhere between 3.2 and 4.3 million South Africans. So I thought it would be interesting just to talk about the different types of research. There's all these different phrases we hear, blue sky research, basic research, and so on. And I think for the purpose of treatment and diagnosis for rare disease patients and those affected by congenital disorders as well, we need to think in terms of translational. Many different definitions for this, but this is where you apply those discoveries to that blue sky research in the lab or the clinic or in the field. And you develop new treatments and approaches to medical care to improve their health. And much of this may be through clinical trials or studies of some kind. Another definition is enhancing the adoption of best practice in the community, but in the most simple terms, it's aimed at solving a particular problem. And it's moving the researcher's bench to the patient's bedside and community. So at the base level, we're talking about someone that has a problem and we need to apply what we've learned in the lab, in the clinic and so on, and apply it to actually improve the situation, the quality of life for that person. You may also have heard of clinical research, and this is research that includes human subjects. And this is largely or should be patient-oriented and it includes those human trials, new technologies, and the mechanisms or the life cycle of the disease. We're talking about epidemiology and behavioral, so how diseases how they're represented in populations as populations change. And we're also talking about outcome research and health services research. So I thought it was the best approach here was to look at what are the benefits of doing research specifically for rare diseases. So in many cases, a rare disease patient there isn't a treatment option available. We saw that only 5% are FDA approved. And so in many cases, patients are having to find some kind of option for treatment, a lot of off-label use and so on. And that research is a necessity for them. In many cases, it's life-saving. In other cases, it's needed to improve the quality of life. There is a large amount of lay expertise, and this did come up earlier this morning with Dr. Chris. And I did raise that question because often the patients are the #1 experts, and they actually hold a lot of knowledge and information about their disease. And they are very often the expert on their disease, with the primary healthcare provider often Googling the disease because they haven't come across it through their career. And it's essential that we actually use that expertise that we have available. And through it, we can also ensure that patient centricity and that the patients are at the center. This kind of research on rare diseases can also increase the awareness around these rare diseases. And as we know that while rare diseases are individually rare, they are collectively common. And so this is something that actually has to be done on an individual basis, but also as a collective. We need to improve that diagnostic odyssey that so many speakers have referred to. It takes on average 7.2 years for a diagnosis. And I really liked what the earlier speaker said about a misdiagnosis odyssey. And that really is the case, seeing 8 to 10 different specialists and getting so many misdiagnoses before you actually find out what is the actual problem. And collaborative research is also essential to advance treatments and improve accessibility to treatment. And coming back to that all-important improved quality of life, whether that's meaning they can actually talk with their family members, or they can actually get out in the fresh air, they can contribute to society, they can go into the workplace or the school situation and have an education. And it makes a huge impact, not only at a personal level for the patient and the family, but also socioeconomically. And there are also a large number of benefits that can be applied to other diseases. And a lot of the mechanisms of diseases within rare diseases is now being applied. And I think this is going to be one of the strongest points of leverage that we are going to have to actually motivate and advocate for improved services around rare diseases. And the socioeconomic impact is huge. There is a cost to not diagnosing and not treating rare disease patients. We just haven't quantified that cost. And I think brick by brick, we're going to have to actually investigate each intervention for each disease to actually demonstrate that what is the cost of care versus the cost of no care. Because I think it is rather naive to think that we can just do it on a cost analysis in terms of the rationing that was spoken earlier by the first speaker today, Dr. Chris. We've got to look at the impact of not treating as well as not justifying for the high cost of medicine for a specific individual. So what are the challenges around rare disease research? So of course, we have low patient numbers because these conditions are rare. In some cases, there may only be 1 or 2 patients globally. And most of these are children, so it does have an impact on the type of evidence base that we can build. I come back to the point that the first speaker made this morning about there's always evidence. There's actually not, and we certainly don't have that rigorous evidence base in terms of random controlled trials that is often needed to inform therapy development. We have large geographical distances between patients, clinicians, and scientists. This may be globally, it may be regionally or nationally. Either way, we know about the large distances in South Africa with just getting to primary healthcare clinics, and that is just multiplied. The lay expertise I referred to earlier is often overlooked, and while patient centricity has become a major focus, particularly in Europe and in the USA and other high developed countries, it's actually, in some other countries, it's almost seen as a tick box in some scenarios, and it's not really gaining traction in terms of how the patient should be at the center. There's very few natural history studies of rare diseases, and this lack of data, this lack of evidence, without that, it cannot inform the future development of diagnostics and therapeutics. The onus is very much on patients and those who are affected to collaborate together and to network. And we've really seen a lot of examples historically and more recently where it has been initiated by the patient who has connected with other similarly affected patients globally or nationally, and then they make a connection with a researcher who then helps focus on identifying the genotype and develop treatments and so on. So it's very much down to the patients, the ones with the problem, to actually initiate. And I think it's important that the patients and the caregivers and the families affected are those that actually can lead the process, but also need to be seen as equals with the clinicians and the decision makers. In South Africa, rare diseases remain unprioritized nationally, hence the need to develop a national strategy. And until we get recognition for this burden of disease that is significant, and we have to quantify that and get the data to support it, it will remain unprioritized. There's obviously less investment and less research going on rare diseases because a lot of more common diseases or competing health priorities have better funding sources or a larger number of funding streams. And then we we don't have that empiric observed data to quantify the problem. And we have to demonstrate there is a problem to inform policymakers that there needs to be a relevant healthcare response. So this slide is a standard slide that's used pretty much in rare diseases, but I have adjusted it because we have the various challenges for a rare disease patient where we've got the dual healthcare system that we are hoping that NHI can help overcome and merge eventually. We have the lack of knowledge and awareness around rare diseases, the lack of data, no local definition, which we're trying to solve. We don't have an orphan drug policy, and it all ends up with limited access, whether it be to diagnostics or therapeutics. And I think all the solutions that are listed underneath, improved surveillance, a policy framework, and so on, all require collaborative research. And we need to underpin everything that we do with an evidence-based approach and collaboration, working together, whether it's concerted efforts or collaborative efforts. So what does collaborative research look like? Well, going through a few articles in the literature, there are quite a number of articles now on collaborative research in rare diseases. And the key themes that come through, that it has to be collaborative or concerted. And going back to the previous speakers talking about coordinated care and diagnostics, I think all of these elements require collaboration, not just research. It needs to be collaborative and focused. Multidisciplinary, that came through very clearly in the previous speaker. There are so many different specialities involved, whether it be in the diagnostic odyssey or in the treatment and the management of the disease. And research similarly requires many different disciplines to actually reach the target of that research project. Patient-centric, it has to be, as outlined previously, translational, it's got to be practical and applicable to improve that quality of life and perhaps even life-saving, and it needs to be sustainable. So what I've done here is I've just shared some examples of efforts that are ongoing internationally, because obviously we have those developed countries that are much further along in the road, and they've also developed a lot of international initiatives and so on that have actually already started along this road previously to us, because we are a number of decades behind other countries as a result of the epidemiology. So, and they focused on 5 main strategies. And this is team science and research networks where people are genuinely working together. You've got the international rare disease research community, and then in other countries, you've got Care for Rare in Canada and so on, and many other examples in the USA. And I'd just like to raise the question, do we have anything like this in South Africa yet? And as far as I'm aware, we don't. We have, for example, the SASHD clinical group and the genetic counseling group and so on, but we need to really get more cohesive as a nation. And I think we need to get more connections between the provinces and the various genetic centers so that we are not duplicating efforts and we are not wasting resources, the limited resources that we have. There's a number of different collaborative and novel funding models, whether it be NORD or Find a Cure and so on. And we need to be more creative in how to fund this research, particularly in the current context of COVID, where a lot of our funding is being redirected to the COVID emergency response. Shared knowledge platforms, Orphanet is probably the best example of this. Starting out in France, now it includes many countries collaborating across the world. And it's a very useful resource. And innovative regulatory frameworks. I think while other countries have got their orphan drug acts and regulations and so on, as in the USA and Europe, I think as a starting point, as one of the first countries in Africa to actually start to get a rare disease strategy on the table is so important. And I think we've just got to keep going to get that done so we can take the next step in helping develop regulations, whether it be for the surveillance of rare diseases under the NAPISA Act and in the many other facets of the regulatory environment. Then patients as partners. There has to be this patient-centric role, whether it's through organizations like Rare Diseases South Africa or the individual advocacy groups for the specific diseases, individual patients and caregivers, and just recognizing them as equal partners in research. So what do we need for collaborative research? We need, and what do we want that collaborative research to actually achieve? We want greater access, opportunities, and support for patients to participate in research, studies, trials, data sharing. There are various tools around, but there isn't anything really consolidated, and that needs to be done. We need to work out how many. We are frequently asked, so how many people are affected by rare diseases, or how many people are affected by CF? And you can do a calculation to some degree and estimate, but we need to get some really robust data so we can really leverage. We need to get rare disease research prioritized at all levels, nationally and provincially. That includes National Department of Health, NRF, the Medical Research Council, and so on. We need the patients and the carers and the groups to really participate actively and help, voice their needs. And that is the responsibility there on the patient and the groups to actually do that. We need education of patients on how does research and development work, how do clinical trials work, and educate on that side so that they are better equipped and empowered to participate. We need research. Sorry, there's a typo here. We need to further develop patient registries that are aligned with biobanks. And I just want to put a quick something here that keep your ears close to the ground in terms of something happening at rare diseases along those lines. And we need that political commitment and action prioritizing rare diseases, and of course the health economic analysis to actually monetize, what does it cost for treatment and for research. And then just to finish up, I just wanted to contextualize this within the Sustainable Development Goals, specifically Goal 3 and those targets. There are a number of targets that are relevant and for rare diseases. But I think the key ones are the aim for 2030 is to end preventable deaths of newborns and children under the age of 5. Our current under 5 mortality rate in South Africa is 35 per 1,000 live births. That's got to be reduced to 25. And the only way, as Prof. Musa outlined earlier, the only way that we are going to further reduce that child mortality is if we tackle rare diseases and congenital disorders holistically at a clinical and a research level and as a whole. And we need to reduce premature non-communicable disease mortality by 1/3 through prevention and treatment. Rare disease, 80% are genetic, and congenital disorders are also genetic, and these are the first NCDs that are experienced in life. And if we're really going to truly achieve universal healthcare, including financial risk protection, access to quality essential healthcare services, and access to safe, effective, quality, and affordable essential medicine for all. And the final one that I've highlighted here in terms of the targets for 2030 are to support rare disease research and development of medicines for NCDs, including rare diseases that primarily affect developing countries. And we just can't leave anyone behind, and we are currently being left behind. And I really believe that collaborative research combined with collaborative and coordinated care and including diagnostics and therapeutics and access is necessary to ensure that nobody is left behind. I had to throw in a graph. I'm well known for it. So I wanted to demonstrate visually here where we are headed in terms of the burden of disease with regards to rare diseases and congenital disorders. The bars represent countries from left to right, more developed countries on the right. And as we move towards further development in South Africa, we can see where our under 5 mortality rate is now at 25 and where we're headed in terms of the proportion of deaths that are due to rare diseases. And I really believe this is a health burden that is going to be equal in significance as COVID, and that we need to be prepared for that. Thank you very much.
Thank you very much, Helen. Very, very informative. Gavin, any questions that have come through?
Yeah, there's one question from Judy. She's asking, is there a forum looking at the cost of care versus the cost of no care? I think what she's indicating is, can we work out, one, what's the burden of disease, and two, what is the cost of disease? And is anybody looking at that?
So it's a massive task. And I think I indicated earlier, it's going to be a brick by brick approach, because quantifying the whole burden of disease and the cost of no treatment for those diseases is vast, and we have to break it down and tackle it one service or one disease at a time. There are another number of health economics groups, research groups around the country. None of them are really focusing on congenital disorders or rare diseases as yet. There is an initiative underway with funding from AMPATH to University of Pretoria, where that is potentially going to be looked at. But again, it's not going to be a quick fix, and it is going to be a long road ahead to do that. But absolutely, and I would think that the no cost, the lack of care will be looked at as a part of that health economic analysis.
But I think also, if I can add, Helen, I think that this is exactly why the international collaboration is so important, because very often you'll find that the international support group meeting, the support groups internationally have done their brick by brick based on their particular condition. And it's a case of actually reviewing that information and then obviously trying to adapt the feedback into relative South African terms. But it's a mammoth task, and I wish that we could say that we would get it right, but I think it's going to take us a long, long time. Yeah. So Gavin, if I can we please pop up the last, we had a couple of poll questions that I failed to bring up. So I'm going to ask Trevor to please pop them up. If you guys, while we're moving on to the closing discussions, etc., if you can, while we are presenting that closing discussion, if you can, please answer the poll questions, just to give us a bit of an indication on what the general audience feeling is with regards to the topics. And, you know, have we kind of addressed the things that we need to, and what are the obvious issues that we may have missed? So the first poll question that's come up at the moment is, do you agree with the following statement, that the South African healthcare system should provide equitable access to high quality services for South African patients living with rare diseases, irrespective of the rarity of their condition? So we'll give you guys about 30 seconds to maybe answer that one before we move over to the next. So again, the question is, the South African healthcare system should provide equitable access to high quality services for patients living with rare diseases, irrespective of the rarity of their condition. And that's a simple, do you agree with that statement or not? So we have about 55% people who've participated, so we'll give it another 10 seconds and then we will move on to the next question. So at this stage, 100% people are saying, 100% of the responses are saying that yes, absolutely, that is what we should be doing. Okay, Trevor, if we can move on to the next poll question, please. So what do you think will improve the diagnosis of rare diseases in South Africa? It's multiple choice. So is it newborn screening? Again, we're looking at improving the diagnosis of a rare disease in South Africa. Is it newborn screening, clinical diagnosis of rare diseases in combination with genetics and genomic technology, clinical interfaces that capture phenotypic information, a focus on diagnosis, ensuring patients with suspected but undiagnosed rare diseases are systemically identified and monitored, the development of a South African undiagnosed rare disease guideline. Undiagnosed rare disease patients have priority access to genetic services and expert diagnostic response, or would it be all of the above? So if you think that there's a very specific preference, you can select that. Alternatively, you can select all of the above. And if I can, I'll give you guys another 10 seconds to go through that. We're sitting at 40, almost 50% already participation. So it seems that 77% have said all of the above. And then other than that, the highest outlier there is a focus on diagnosis, ensuring patients with suspected but undiagnosed rare diseases are identified and monitored. So quite interesting results there. And then Trevor, if we can, please move over to the fourth question. What do you think?
Sorry, Kelly, I'll be with you in a second. So
Okay.
This is now the fourth poll. Here we go, launching it.
Thank you. Do you believe that a coordinated approach to diagnostics and care will contribute to an equitable South African healthcare system and better health outcomes for people living with rare diseases? So again, do you agree with the statement? Do you believe that a coordinated approach to diagnostics and care will contribute to an equitable South African healthcare system and better health outcomes for people living with rare conditions? So off the bat, I'm seeing 60% participation there, and the results are again 100% agreeing with that statement. So that's quite interesting. Gavin, if I can hand over to you, please, for some closing comments.
Okay, so thanks, Kelly. I think we're going to end on time. I think that's very positive. The second thing is I just want to thank the 5 excellent speakers. I'm going to run through sort of my key take-homes from the 5 speakers. But I think that in the way that the meeting was constructed, it took an outside-in view from the broadest possible perspective right down to the patient experience perspective. So I think that really has a real power to cover the topic in such a nice way. What I heard from Dr. Crisp is be patient advocates, keep the faith, raise the voice of the patient always, and engage with the healthcare system. And I think those are very positive words from someone who's leading the charge in terms of healthcare reform in South Africa. What I heard from Dr. Mayette is NASPISA has a framework of notifying diseases in terms of broad other diseases, but she did propose quite a nice framework looking and isolating rare diseases, which I think we should take on and engage with and say, how do we do this? And how can we make it possible for RD to be notifiable in its own subset and that it's captured in a certain way? So I think a really strong message and a proposal from Dr. Mayette. What I heard from Prof. Musa is a lack of genomic support, fragmented system in terms of provincial coverage, numerous challenges that need to be addressed, lots of work to be done, real coordination of care needs to be done. And what she was saying that struck me is, yes, we need a national policy, but what struck me in terms of her saying that the families and the NGOs and the communities really have real insights in helping treat our patients. And that came through quite strongly for me as well. What I heard from Cochrane is this is a very complex area of genomic counseling where there's limited resources. There's lots of education needed because there's multiple tests that can be done. And we want to limit that odyssey of a journey for these patients. So we really need people to be upskilled and understand what's available and what tests should be done at what point in time. Very strongly, I heard from her is affordability is limiting access to these tests. And that from our policy framework document, I think we need to take up and strengthen in our document going forward. And what I heard from Helen Malherbe is there is a need for collaborative research because we can only make better policy decisions for rare disease patients if we have data and research that's multidisciplinary and covers very broad areas. She did, in my view, tell us that there is international precedent, so we don't need to reinvent the wheel. And I think we need to look at those precedents and including it in our rare diseases framework. And yeah, those were the key takeaways at a high level that I heard. So for me, really insightful contributions to our rare diseases framework, our policy framework document, which we will include. The next steps from our point of view are to include your inputs today into our document within the next month, and then recirculate that document. Post that, we want to start engaging with our key stakeholders to say we now have a policy framework document which has broad consensus across multiple stakeholders. How do we move towards implementing some of the key initiatives that are articulated in that framework document? So this will be a work in progress going into 2022. And for me, I'd just like to quote a Ted Kennedy quote who says, "The dream endures and the work continues." And for us as patient advocates who believe in treatment for rare disease patients, we really need to keep that dream alive and to keep working in terms of what we need to do. My final comment is just a word of thank you to Kelly as Rare Diseases South Africa and her team of putting this together. There was quite a lot of preparation and quite a lot of work that went into it. So thank you, Kelly, for that. On behalf of the Rare Diseases Access Initiative, SteerCo, really thank you for participating and making your contributions. This has been 18 months worth of work to get to this point, and we continue the work. And I hand over to Kelly just on the final thought. Thank you very much.
Thank you very much, Gavin. I just would also like to really say thank you to Trevor for providing us, from Echelon Link, for providing us with the tech support today. Really, really welcomed. I think we've all had tech issues over the last couple of months. So it was really, really nice to know we had someone on hand to assist. And also just a big thank you to all the actors and stakeholders within the Rare Disease Access Initiative for listening to our continuous squeaky wheel, so to say, in putting a collective group together. A big thanks to IPASA for providing the secretarial support as they do to that grouping. And a massive thank you to everyone who's taken the time to participate and listen today. Just a reminder from us from a patient perspective that there are thousands of patients that are hugely reliant on us moving the needle forward. And there's a willingness from a patient community perspective to do and to have these conversations and to drive whatever's necessary, but we need partners to be able to do that. And we thank everybody who's taken the time to partner with us this morning in listening, in understanding, and we really look forward to hearing your feedback on this framework that we have developed this far, so that we can make sure that we've put a robust framework in place that we can then move on to implementing. So thank you very, very much to everyone. I'm glad we've ended on time, and I hope you guys have a wonderful day further.